Name of this workshop is of Predictive Biomarkers of Toxicity and Immune Response in Advanced Melanoma. What is cause for people who are not in cross-section? Many of you here are already in some member of some cross-section. This is pan-European intergovernmental framework for promoting networking among European researchers. Generally, like this event is a networking event. Together with the Horizon Europe is one of the most important programs for promotion of cooperation across Europe in science and activities. Why we are this action is so-called immunomodel with this number. Generally, idea of this action is to foster research and innovation of the field of preclinical immunology with the ultimate goal to advance in the treatment on cancer patients and improve their outcome, survival, disease prognosis, and for sure quality of life. Why we choose melanoma? Because melanoma is emerging. It's a problem in our society. We are still seeing, like clinicians, we are seeing more and more younger patients. But in the last, let's say, 10 years, the landscape of treatment of especially advanced melanoma has dramatically changed. So, with introduction of new treatment therapies, combination strategies, we have, let's say, immunotherapy, which is cornerstone of treatment of advanced melanoma. We created two-day program regarding this topic. In first day, we'll clean more. It will be more melanoma diagnosis treatment. We dedicated, which will our colleagues from dermatology, surgery, nuclear medicine, and pathology will speak regarding melanoma diagnosis treatment. We dedicated one speaker, which will in the session will like a separate topic role of radiotherapy because now we have this connection of radiotherapy and immune response. In session 3 we will talk about predictive biomarkers and immunotherapy, and the last session today will be toxicity of immunotherapy. Tomorrow we will talk about real-world data of melanoma treatment, then genetic biomarkers, and finally we are ending the workshop with interactive approach for biomarkers, when we have invited speakers from which are working in this field. So that's for me now. I'm Professor Igor Stoikovsky from clinical oncologist. I wish you successful and interesting 2 days. I will now put the floor on Professor Jovanovic, who is Vice Dean for International Cooperation of Medical Faculty at University of St. Cyril and Methodius in Skopje. So, please.
Thank you, Professor Stoikovsky. Ladies and gentlemen, esteemed colleagues and dear guests. Good morning and welcome to this meeting committed to the interdisciplinary approach to dealing with melanoma. Professor Stoikovsky announced he is the Vice Dean for Cooperation Faculty in Skopje, but I would rather be presented in this context as a pathologist working surgical and molecular pathology. I'm very pleased to have the opportunity to be part of this workshop, especially organized to be organized at the Medical Faculty St. Cyril and Methodius University in Skopje. This is our oldest faculty in this country, founded on March 17th, 1947. Speaking about melanoma, complex pathology, and having in mind its relentless rate of progression. it requires a multifaceted approach if we tend to have an effective management of this disease. Regarding this problem, we have gathered here I would say a vast and diverse specialties, including different specialties of medical practitioners, molecular biologists, pharmacists, geneticists, and we have even mathematicians among us. Together, I think that we can compose a formidable force that combining our knowledge and our different fields of expertise, we should and we must cultivate solid and fertile ground for enabling further collaboration, maybe some innovation and discoveries in this field. As we deal with the complex biology of melanoma and explore different avenues for action regarding this disease, we should bear in mind the ultimate beneficiaries of our mutual efforts, and that would be innumerable individuals whose life has been touched by this dreadful disease. So during the next few days, we should make our efforts bring together our knowledge, our intellect, our ingenuity, and also compassion towards alleviating their troubles and bringing again light into their lives and hope for a brighter melanoma-free life. Let me extend my deepest gratitude to all of you for your waveless support and commitment to this noble cause. Thank you very much, and let's proceed with the workshop. Now I call Dr. Zorica Zafirovic from the University Clinic of Dermatology she's our first speaker and she will break the ice by elaborating the melanoma epidemiology and risk factors. Thank you. Okay.
Good morning, dear colleagues. At start, I want to thank a lot Scientific Committee for the kind invitation. So it's my great pleasure to present my lecture, which is actually focusing on the melanoma epidemiology and risk factors. Enter. Yeah. We all know that melanoma is a tumor with high impact through its rapidly growing incidence, high mortality and increased complexity and high cost of care in advanced stages. We know also that melanoma arises through malignant transformation of melanocytes and typically occur in the skin, but rarely also in mouth, intestines or eye. But we are dermatologists, and in our dermatology practice we are facing with these clinical pictures. So cutaneous melanoma is the most common subtype of melanoma, accounting for more than 90% of melanoma cases. is the most aggressive, we also know, and lethal form of all skin cancers. We know how it is the pathway of forming this kind of cancer, and represents also 5% of all skin cancers and 3/4 of all skin cancer deaths. The incidence in the world has risen rapidly over the course of the last 50 years in people over 60 years of age, and in general in all age groups. Melanoma incidence, unfortunately, is increasing in wide-skin population, especially where fair-skinned individuals are subject to excessive sun exposure. These are prevalence data of skin cancers in Australia. According to Global, melanoma is reported as the 18th most common cancer worldwide. These are graphics. And incidence trends in the world, they are very different among different populations, depending on ethnicity. We know that the highest rates are in New Zealand and Australia, and it reaches 60 cases per 100,000 population. The rates are intermediate in Europe and the United States. And in Europe, the rate is about 25 new cases of melanoma per 100,000 population. And it is interesting that the lowest rates are in South Central Asia. What is the reason for this marked incidence variation? Maybe could it be associated with cultural and wealth differences influencing the sun exposure time? Another important reason, I think, and could it be to the fact that many European countries don't have a cancer registry, or this is not rigorously updated. There are differences by ethnicity, and they observed for cutaneous melanoma subtypes and body location, and about most common melanoma subtype among population of European origin is superficial splitting melanoma. And the melanomas in the African American population, they are on the palms and the soles, and acral indigenous melanoma, it is the most common histopathological type. About the distribution, there are differences between men and women. In men, the most frequent site was the trunk, 43%, and in women, the legs. It is interesting that the incidence rates start to increase from 40 years of age, and is generally considered a tumor affecting young and middle-aged people, and the age range with highest number of melanoma diagnoses is between 40 and 60 years. And the median age of diagnosis and death are 57 and 67 years. Age. About the age, adolescent and young adult women have higher melanoma incidence rates than men. And this may be in part due to the greater use of sunbaths by girls, which is associated with increased melanoma risk. We know that in general girls have greater telling risky behaviors and socially determined aesthetic needs. After the age of 40 years, rates reverse and the incidence of melanoma among men is greater than that of women. Because men are less likely than women to examine their own skin or seek help from dermatologists for skin examination. Considerable sex differences in melanoma awareness and detection practices have been reported in population-based studies. What about mortality? Looking at mortality rates, they were found to increase in the United States and in Europe since 1980s, but at much slower rates than incidence. And at all ages, mortality rates are higher in males than in females, possibly due to the later presentation of the disease. There is one analysis from the European Organization for Research and Treatment of Cancer, one trial which showed that in both localized and advanced disease, women have a significant and independent advantage concerning disease progression and survival. These are data from GlobalCan. About the incidence in Europe, because we are in Europe, has been constantly increasing in all European regions for the last few decades. And the data available draw a highly heterogeneous epidemiological picture of melanoma in Europe. The highest estimates of melanoma incidence rates were observed in Denmark, Norway, Sweden and Netherlands. And important differences in the sources and availability of accurate epidemiological data exist among European countries and regions. Unfortunately, melanoma continues to claim more than 20,000 lives annually in Europe, with the highest proportion in Central Eastern European countries. These are age standardized rate per 100,000 in males and females. And these are numbers, incidence for both sex in North Macedonia, in our country. The sources of this is very important. The sources of epidemiological data for melanoma in Europe, and we have dated that 22 European countries have quality national population-based cancer registries covering the entire population. In contrast, 9 countries in southeastern European region report only estimated incidence rates calculated from partial registration data and neighboring countries' quality registries, unfortunately. And these are characteristics for countries in the eastern half of Europe report. They are the lowest incidence rates, with high case fatality, with increasing mortality, a higher proportion of thicker tumors. We have late diagnosis and lower survival rates. And unfortunately, they're least well equipped with quality cancer registration and reporting, and they lag behind an efficient cancer control plans implementations. About the mortality in Europe, mortality has increased in Europe, although at slower rates than incidence. It is very difficult to speculate on future developments in mortality, we have data that efficient therapies have been introduced in European countries, yet across them is highly uneven across the continent. What about risk factors? There are different risk factors from genetic factors and environmental factors, and they have been identified by epidemiological studies. The genetic component is part of the increased risk, although it's not the main factor. And the most important exogenous factor of melanoma is UV exposure, particularly intermittent sun exposure. We have one schematic representation about the genetic and UV radiation, and this demonstrating very complex interplay of multiple melanoma risk factors, often beyond our control. Phototype, nevus count, ultraviolet rays. There are risk factors, and the most common phenotypic risk factor is sunburn-prone skin. We know that the gene variant melanocortin-1 receptor are the most important underlying genetic determinants studied in the last decade. Also, individuals with a high number of common nevi and those with a large congenital, multiple, and atypical nevi are at high risk. And the most important, I said, exogenous factor is intermittent sun exposure. It's very important, these groups of patients to go through follow-up and clinical monitoring. Pigmentation is very important and with significant influence on skin susceptibility to malignant change. There are many polymorphisms of gene melanocortin-1 receptor, which determine the different skin phenotypes. So, red hair and fair skin phenotype express a low pigmentation, and the result is increased sensitivity to ultraviolet light and increased risk of melanoma. In addition to characterizing the phototype, melanin is evolving in defending melanocytes and keratinocytes from UV light, and this explains why phototypes 1 and 2 are at higher risk of developing melanocytes and keratinocytes cancers. Also, a high number of acquired melanocytic nevi, the red hair phenotype, and these alleles from genes are independently increased melanoma risk. This is supported by a study carried out in Australia and Queensland. Also, several studies have shown that the main factors associated with the development of a melanoma are the number of nevi, melanocytic nevi, family history of melanoma, and genetic. In terms of nevus count, melanoma in most cases arises on healthy skin, although 25% of melanomas are associated with a pre-existing nevus, and this justifies the double incidence of nevus associated melanoma in young adults and elderly. In addition, the number of moles is associated with the risk of developing melanoma, especially in cases of more than 100 moles or moles with dysplastic appearance. There are observational studies which suggest a strong association between a high number of nevi and melanoma. Ultraviolet rays, they are very important, and most melanomas arise on skin sporadically exposed to the sun, in sites and individuals who are more prone to sunburn, especially repeated intense sun exposure. This theory is further strengthened by the observation that patients with melanoma who actively reduce their sun exposure after initial diagnosis are consequently at reduced risk of developing a second primary melanoma. This is also interesting. The individuals with dark skin or skin that darkens easily in response to sunlight, who doesn't burn, have lower rates of melanoma. However, sun exposure is not directly related to melanoma development, as evidenced by the fact that melanoma can also occur in sites that are not chronically exposed to the sun. What about age? The age at which sun exposure or sunburn occurs also appears to be important. There are many, one of them, systematic review, strongly associated intermittent sun exposure in childhood or adolescence with an increased risk of melanoma. Individuals who experienced more than 5 severe sunburns had a 2-fold increased risk of melanoma. Personal history of sunburn in childhood is associated with a higher risk, and intermittent exposure is associated with melanoma. One of the most important risk factors in the etiopathogenesis of melanoma is UVB exposure, but UVA exposure doesn't come without risk. This is a very important topic. Artificial UV exposure may play a role in the development of melanoma. We know that sunbeds emit UVA radiation, and a meta-analysis of studies that explored the incidence of melanoma following sunbed use reported a 75% increased risk in individuals under 35 years of age with a history of sunbed use. Because of these consequences, unfortunately, in many states, the use of sunbeds has been banned. This is very interesting association between melanoma and comorbidities, especially for immunosuppressed individuals who underwent organ transplantation. There are risk for melanoma, and according to recent data, transplant recipients are at more than double the risk of developing melanoma overall when compared to the general population. Also, other skin malignancies like basal cell or squamous cell carcinomas or mycosis fungoides, patients who present this kind of malignancies are at higher risk of developing melanoma and subsequent death from the disease. About the genetic factors, I said a family history of melanoma is a strong risk factor for the disease, and considering that familial clustering of a disease is an indicator of possible heritable causes, there has been an explosion of research in the past 2 decades directed at elucidating the genetic basis of melanoma. Genetic factors such as skin phenotype, as well as familiarity, that counts for 5 to 10% of melanoma's origin. Some of these, such as atypical familial multiple moles and melanoma syndrome or dysplastic nevus syndrome, where individuals have multiple moles at high risk for melanoma. Many individuals don't meet this diagnostic criteria for these syndromes, but still have numerous nevi, often due to cumulative sun exposure. A personal history of cutaneous melanoma is also very known risk factors for additional primary melanomas. All of these criteria are of great clinical value because patients with so many nevi, with familiarity for melanoma and with dysplastic nevus syndrome, they are monitored nowadays with digital dermatoscopies, and they should performing total body dermatoscopic examination. Very important. About the prevention campaigns in Europe, it is very important to say that there are disparities in incidence and early diagnosis across the continent, and that is related to significant differences in the level of population awareness and available primary and secondary prevention campaigns. We know that Western European countries and Northern countries, they have a several decades long tradition of public education campaigns for skin cancer prevention and early detection. And only one country in Europe, Germany, is the only country implementing a national skin cancer screening program. And about Euromelanoma, we know that is the Pan-European Skin Cancer Prevention Campaign, also in our country, and campaign has achieved major progress for most countries in the region, almost in all Europe. My conclusions for my lecture will be the first worldwide data indicates an increase in the incidence of melanoma, although primary and secondary prevention campaigns. It is interesting that there is a 5% reduction in the incidence of thin melanoma in individuals between 15 and 24 years of age, suggesting that preventive measures are effective. While it is possible for early diagnosis, there are non-modifiable risk factors that must be evaluated for each patient, and there are phototype, number of nevi, familiarity for melanoma, and it is necessary to remove known risk factors, and they are avoiding sunburn, also tanning lamps, and avoiding exposing to the sun without using sunscreen. What about sunscreens and vitamin D? Study showed that broad-spectrum sunscreen that prevent erythema are unlikely to compromise vitamin D in healthy populations. Based on this data, we recommend a daily broad-spectrum sunscreen with high UVA protection, which doesn't compromise vitamin D status in healthy people, and should always be used regardless of the season, every day. Also, it is necessary to implement screening campaigns even in younger age groups, and inform patients about the importance of annual dermatological checkup. Also, to improve secondary prevention, it is essential to disclose easy rules such ABCD rule or the ugly duckling sign. What does it mean? That a mole different from the others. and they are still effective today for the early diagnosis of melanoma. Also, very, very important is development of new technologies such as dermoscopy, video dermoscopy and confocal microscopy, which also increased a lot the diagnostic capacity in small melanocytic lesions. That's important. Thank you for your attention. My end.
Thank you. Thank you, Dr. Zafirovic. Because we are tight on time, all questions and answers you can post in the in the chat box if you're online, or we will The next speaker is Professor Duma from Medical Faculty Skopje. Her presentation is about dermatological approaches in melanoma diagnosis, please.
Okay. Thank you. Dear friends and colleagues, I would like at the beginning to wish you a pleasant and productive 2 days of meeting. Thanks to organizers for invitation. It's a great pleasure to be a part of this meeting. Да продължам или? Да? Okay. Okay. As we see, we are at the beginning of this journey to melanoma because we are dermatologists and we are the first point to diagnose and to others approach. Today I will speak about dermatological approach of diagnosis. As we already know, melanoma is the most serious form of skin cancer. It is the 5th most common cancer in males and females in USA. Its incidence increase with age, and survival rates depend on the stage of the disease at the time of diagnosis. We already know that early diagnosis is crucial to improve patient outcome and save lives. There is new classification of melanoma, who is from 218 classification is there is 8 groups of melanoma. The first one is with low UV radiation. Here is superficial spreading melanoma. The other one is with high UV radiation, lentigo-maligna melanoma and desmoplastic melanoma. And the other group is low to no UV radiation exposure, which is malignant Spitz tumors, Spitz melanoma, acral melanoma, mucosal melanoma, and melanoma in congenital nevus and melanoma in blue nevus. According to the traditional morphology classification of melanoma, there are 4 major subtypes of invasive cutaneous melanoma, as we know: superficial spreading melanoma, nodular lentigo-maligna, and acral lentiginous melanoma. Superficial spreading is the most common histologic subtype, approximately 70% of all melanomas. Over 60% of superficial spreading melanoma are diagnosed as a thin, highly curable tumors, less than 1 millimeter in thickness. Superficial spreading melanoma is subtype most likely to be associated with pre-existing nevus. About the anatomic site, has predilection regia in the males on the back and in the females on the extremities. Superficial spreading melanoma typically presents as a variable pigment macule or a tiny plaque with irregular borders ranging from few millimeters to several centimeters in diameter, and lesions may have multiple shades of brown, red, blue, black, gray, and white. Nodular melanoma is the most second common type. They may appear as a darkly pigmented or polypoid papules or nodules, but frequently present with a uniform color or amelanotic, with symmetric borders and a relatively small diameter, making early detection very difficult. While the majority of superficial spreading melanomas and lentigo malignant melanomas are diagnosed at least than a 1 millimeter thickness, most nodular melanomas are thicker than 2 millimeters at the time of the diagnosis. Lentigo malignant melanoma is the most common arise in a chronically sun-damaged skin. His look like tan or brown macules. The lesion gradually enlarge over the years and may develop a darker asymmetry, pigmentation, and color variegation. Lentigo malignant melanoma account from 10 to 15% of all melanomas and is particularly found in older individuals. Acrolentigenous melanoma is subtypes who account for less than 5% of melanomas and arise most commonly on palmar, plantar, and subungual surface. Acrolentigenous melanoma first appear as a dark brown to black irregular pigmented macule or patch with rise area, ulceration, bleeding, large in diameter, generally a significant deeper invasion in dermis. Occasionally, acral melanoma can be present as an amelanotic or hypomelanotic lesion mimicking benign disease, such as warts, calluses, tinea pedis, non-healing ulcer, or ingrowth toenail. Subungual melanoma arise from the nail matrix and usually present as a longitudinal brown to black band in the fingernail with or without nail dystrophy. There is also uncommon variants, rare types of melanoma, which is amelanotic melanoma. It's maybe most difficult for diagnosis, schizoid melanoma, desmoplastic melanoma, and animal type of melanoma. When we do our diagnosis at the beginning, we take a history. The first two columns are the dermatology diagnosis. The third column only accept the biopsy we take sometimes. It's not our part in diagnosis. At the beginning, we make history of patients and risk factor, but my colleagues speak about that, and I will go in the other part, which is skin examination, clinical production rules, and challenging region, also the supportive technique for clinical diagnosis. The clinical recognition of melanoma may be challenging even for the most experienced dermatologists. Sensitivity of the clinical diagnosis of experienced dermatologists by the naked eye is approximately 70%. However, the use of diagnostic aids such as dermoscopy, which requires some training, may greatly improve the sensitivity and specificity of the clinical diagnosis. At the beginning, we say history and risk factor. When we speak about skin examination, there is also three main parts. The first part is visual analysis and pattern recognition. Typically assess whether a given pigment lesion has one or more features that may suggest melanoma, including asymmetry, irregular borders, variegated colors, and diameter more than 6 millimeters. The second one is comparative analysis of nevus pattern in individual patient. What that means? The interpatient comparative analysis use the so-called ugly duckling sign, which refers to the presence of a single lesion that does not match the patient nevus phenotype and the dermatologist's so-called signature nevi. And the third part of clinical diagnosis is dynamic analysis, a history of changing in size, color, shape, or pre-existing melanocytic lesion. This is the most important clinical criteria for the diagnosis of melanoma. The diagnostic accuracy of visual inspection was examined in a systematic review and meta-analysis of 49 studies performed in dermatology setting that reported accuracy data for the diagnosis of melanoma based on over 34,000 lesions, including 250 melanomas. In a subset of 6 studies of in-person evaluation by visual inspection of participants presenting for the first time with a suspicious pigmented lesion, the summary sensitivity and specificity were 92.4%. Also, in clinical diagnosis, we have clinical prediction rules. The one that I mentioned is the ugly duckling. The other one is the most famous algorithm, ABCDE rule for melanoma. Also, we use the Glasgow Revisit 7-point checklist like a clinical algorithm. The use of this criteria by primary care clinician may improve their ability to detect lesion suspicion for melanoma at an early stage and inform the decision to refer for dermatology consultation. Clinical production rules, the ugly duckling sign is based upon the observation that in an individual with multiple nevi, the nevi tend to exhibit one or more predominant morphologic subtypes, the signature nevi, defining a relatively specific profile. A pigmented lesion that is obviously different from the others in a given individual must be considered suspicious, and that is a sign of ugly duckling. Clinical prediction rule, ABCDE, we already know. When A is symmetry of the lesion, B is border, C is color variegation, D is diameter, and A is evolution. Also, in clinical practice, in clinical diagnosis, we have challenging lesions, less common subtypes of melanoma, such as nodular melanoma, desmoplastic melanoma, amelanotic and hypomelanotic melanomas, and melanomas of the nail unit, and also challenging part is melanoma in children. When we speak about pink lesion, the ABCDE rules or criteria is not applicable. We have another rule, EFC, when E is elevation, F is firm on palpation, and G is continuous growing for 1 month or longer. Also, we have challenging lesion and algorithms, clinical algorithms for the nail unit, which A is age, African American, Asian, and Native Americans. It's not unusual because this type of melanoma is very usual in these regions. B is brown to black band, C change in the nail band, D it most commonly involve extensions of the pigment onto the proximal or lateral nail fold, and family of personal history for melanoma. Also, another challenging lesions are and who need special algorithm are part of pediatric melanomas, when A is mostly amelanotic, bleeding, color uniformity, de novo, color C is for color ulceration, and P is for pyogenic granuloma, because like lesion, because in this period of life in pediatric population, we have very often we have pyogenic granuloma, and maybe it's better when we have pyogenic granuloma who is not clear cut to send to the pathologist. Also, now I will speak about support technique for clinical diagnosis. On our clinic, we work dermoscopy, multispectral imaging-based system with artificial intelligence, and also this type of support needs other instruments. Dermoscopy is a non-invasive in vivo technique primarily used for the examination of cutaneous lesion. Dermoscopy is performed with a handheld instrument called dermatoscope. The procedures allow visualization of the subsurface skin structures in the epidermis, at the dermoepidermal junction, and in the papillary dermis. These structures are usually not visible to the naked eye. The dermoscopic images may be photographed or recorded digitally for storage or sequential monitoring for change. We have three types of dermoscopy, dermoscopes: non-polarized, polarized, contact, and non-contact. Generally, this is in vivo surface microscopy, and the visualization of with dermoscopy, we visualize the colors and structures in the epidermis, papillary dermis, has generated a new terminology for the morphologic description of the skin lesion. Also, a histologic correlation has been established for the most of structure we seen in dermatoscopy. Dermoscopy structure in melanocytic lesion, the most important one is pigment network. On the left side we have pigment network and negative network. On the right side we have some of the structure we see in benign, some benign, or some malignant tumors. At the C and D we see some structures like streaks, pseudopod, and radial streaming, which we will see in dermoscopy diagnosis in melanoma. The special criteria, special features dermatoscopic for melanoma are atypical pigment network, negative network, shiny white streaks or lines, atypical blotches, blue-white well, atypical vascular pattern, irregular streaks, atypical dots or globus, angulated lines creating a zigzag pattern or polygons, regression structures, and peripheral tan structureless area are some of the features associated with melanoma. But it's not always so easy. Like in life, here we have two melanomas. We have a clinical dermoscopy picture and histopathology. The first one is melanoma, superficial spreading melanoma, Breslov 0.1, and it's very tough to see even with dermoscopy. And the other one there is melanoma in congenital nevus, melanoma in situ, Clark level 1. Several factors may affect the diagnostic performance of dermoscopy. Experience of the examiner, diagnostic algorithm and threshold for a positive test, clinical context, and patient-related factors. What is the benefits of dermoscopy? Dermoscopy improved the diagnosis of melanocytic lesion. Several meta-analyses of studies performed in experimental and clinical setting have indicated that dermoscopy increased the sensitivity for the diagnosis of melanoma without decreasing specificity compared with the naked eye examination. Also improved the confidence in diagnosis of benign pigment lesion and reducing the number of unnecessary biopsy. Several retrospective studies examined the number of excised benign and malignant lesions in dermatologic practice before and after the introduction of dermoscopy. In one study, the ratio between benign and malignant excised lesion decreased from 18 to 1 to 4 to 1. Also, these days we have a privilege in our clinic to work with sophisticated multispectral imaging based system with artificial intelligence. We make total body mapping. We have a special population. That population are patient with multiplying nevi, patient with familiar history of melanoma. At the baseline, clinical documentation of lesion size and appearance, if possible, baseline clinical and dermoscopic at the beginning, we make a baseline of clinical and dermatology photography, and then we make a follow-up if it's needed after 3 or 6 months. A Canadian prospective study compared the diagnostic performance of dermatologists beside examination, teledermoscopy, and 4 imaging analyzer system like PhotoFinder in 180 patients with 209 lesions that were subsequently excised and histopathologically diagnosed. Using the histopathologic diagnosis as a reference, the sensitivity and specificity of the automated system were 82.5 and 55.4%. Also, I must mention the reflectance confocal microscopy. In clinical practice, reflectance confocal microscopy may be an addition to clinical and dermoscopic examination for lesions with equivocal clinical or dermoscopic feature, and is an imaging technology that allows for the in vivo identification of cells and tissue of the epidermis and papillary dermis with nearly histologic resolution. When we speak about diagnosis, at the end we must mention the differential diagnosis of melanocytic lesion, which are common melanocytic nevi, atypical melanocytic nevi, traumatized blue lentigo, ink spot, or spitz nevus. Differential diagnosis for melanoma in non-melanocytic lesions. The most great mimicker is pigmented basal cell carcinoma, rarely pigmented actinic keratosis, seborrheic keratosis, pyogenic granuloma, especially in pediatric population, cheryangioma, dermatofibroma, or keratoacanthoma. And when we speak about differential diagnosis for acral lesion, we can mention varicose squamous cell carcinoma, melanonychia striata, acral melanocytic nevi, subungual hematoma, pyogenic granuloma, and periungual warts. This is not conclusion. This is my vision of the things. If you want to be better in diagnosis or in stopping melanoma, we must work on prevention, education, experience, and multidisciplinary collaboration like this one. At the end, this is not my quote, this is quote from German poet Goethe. We see only what we know, and this is my motto in my work. Thank you very much.
Thank you, Sylvia, for a very comprehensive lecture about diagnosis. So, I want to announce research associate Bisera Nikolovska from University Clinic of Plastic Surgery, and she will, next presentation will be about surgery in melanoma. Please, Bisera.
Thank you so much about your invitation. So I'll skip the introduction because our previous colleagues explained in depth everything about melanoma. So surgery remains the mainstay of treatment of primary melanoma, and in a majority cases is curative. Appropriate surgical management is critical for the diagnosis, staging and optimal treatment in both in situ and invasive primary cutaneous melanoma. So, what is the role in surgery in diagnosis and staging? We all know that for diagnosis and staging, the dermoscopy, the biopsy, the imaging techniques, the tumor markers, the fine needle aspiration biopsy, and the sentinel lymph node biopsy are required. So, surgery helps in the diagnostic biopsy of the suspicious lesion and the sentinel lymph node biopsy. What is the standard protocol for skin lesions suspicious for melanoma? So,
Please, thank you. Sorry for some technical glitches.
okay, no problem. I'll go one slide. So, as I said, surgery is important in diagnosis of melanoma in the excisional biopsy and sentinel lymph node biopsy. What is the standard protocol for skin lesions suspicious for melanoma? As said before, the dermatologist sent us the patients with suspicious lesions for melanoma, and every suspicious pigmented lesion should be biopsied, should be done diagnostic excision with 2 to 5 millimeters of safety margin in order to have pathohistology results of melanoma or some other diagnosis. After the diagnosis of melanoma, wide excision should be done and sentinel lymph node biopsy depending of the pathohistology findings. So this standard protocol has a timeline. So when dermatologist refers patients to us, we should do the excisional biopsy in 4 weeks maximum, and we should have the pathology report in 2 to 3 weeks maximum. So the white excision and the sentinel lymph node biopsy should be done as early as possible. So why do we do the excisional biopsy first? Why don't we do the white excision? Because we need the breast lobe thickness in order to assess the surgical margin for the melanoma. Why? Because we have this quote in life to measure twice and to cut once. This is my most recent example of why should be a diagnostic excision done first, because this is a young patient that he was referred by a dermatologist with dermatology results of nodular melanoma, which was bleeding. So in this case, we decided to do the white excision because with the bleeding melanoma with ulceration is always a high risk lesion. So we did the white excision in 2 centimeters, but we get the result of hemangioma, as Professor Duma already said. That's a differential diagnosis for melanoma. What is the surgical treatment for melanoma? As I said before, it's the white local excision, the sentinel lymph node biopsy, the lymph node dissection, and we have surgery for metastatic disease, for intransit metastasis as satellite lesions. The safety margin in depth must be equal to the minimum safety margin, and excision below the deep fascia is not required. So these are the guidelines of the left side of the slide by NCCN and ESMO about the margin recommendation according to the breast lobe thickness. So every biopsy that we do re-excision of the skin according to these guidelines. These are some of the reconstructive options for melanoma surgery, but in interest of time, I won't be speaking about them. This is a case that I show. This is a clinical case of melanoma of the back and white excision with the margins of 2 centimeters and reconstruction with keystone flap. Why did we do here white excision in the first place? Because we had the disease confirmed, because he had axillary lymph node disease confirmed by fine needle biopsy aspiration. When do we do sentinel lymph node biopsy? The indication for sentinel lymph node biopsy is melanoma thickness of more than 0.8 millimeters. The guidelines were above 1 millimeter, but now the thickness is above 0.8, so the criteria go even less. What is the sentinel lymph node biopsy? The lymphatic mapping and sentinel lymph node biopsy is the standard approach to management of patients with melanoma in whom there is a substantial risk of regional node metastasis. The concept behind the lymphatic mapping is that the sites of the cutaneous melanoma have stepwise patterns of lymphatic spread, and then one of or more nodes are the first to be involved with metastatic disease within the given lymph node basin. If the sentinel lymph nodes are not involved, the entire basin should be free of tumor, so the patient is this is the most sensitive diagnostic procedure that we can have for lymphatic spread. This is an interdisciplinary procedure that requires a surgeon, a nuclear medicine specialist, and a pathologist, of course. We marked the lesion with the nanocolloid marked with technetium-99 metastable, and it's ejected next to the primary lesion or around the scar after the diagnostic excision. The method is very reliable. The accuracy is more than 95%, and less than 5% have false negative results. In my experience in 10 years doing of sentinel lymph node biopsy, I have only one case with negative sentinel, which had lymphatic spread after 3 years. So, sentinel lymph node biopsy should be performed no later than 3 months after the histological diagnosis of the primary melanoma. And it is very important to know that in patients with clinically established metastatic lymph nodes, we perform therapeutic dissection of the entire lymph node basin. We do not do sentinel lymph node biopsy if we have positive, clinically positive lymph nodes or established by ultrasonography, CT scan, or other methods of diagnostics. So excision of individual lymph nodes, just metastatic lymph nodes, is in melanoma is not allowed, and it can spread the disease. So this is the STARS classification about the sentinel lymph node. Our colleagues from pathology will explain this in depth, I guess. So for us, in general, if the metastasis is lower than 0.3 millimeters, the patients have same prognosis as the patients with negative lymph nodes, and we proceed with regular follow-up. The metastasis between 0.3 and 1 millimeter benefit from either the lymph node dissection or adjuvant systemic therapy, and the metastasis above 1 millimeter, they warrant adjuvant systemic therapy and completing, of course, of the dissection of the lymph nodes. Patients with negative sentinel lymph node continued the complete regular follow-up required by the guidelines. So this is one example of a patient with atypical nevus syndrome. So I excised 4 lesions of melanoma, and in this case it is very difficult to to predict or to do to choose one lesion to do the sentinel lymph node biopsy. Lucky for us and for the patients, we chose one lesion that it was, I think, 16 millimeters in depth, but and we had very interesting pathology results. So we found isolated tumor cells in both sentinel lymph nodes. So he had metastasis in both axillary lymph node basins, and the patient, of course, his staging went to stage 3 and received adjuvant immunotherapy. What is the lymphatic node dissection? It is removal of the entire group of lymph nodes, like in the neck area, axillary, or groin, and block. Excision of individual enlarged lymph nodes, as I mentioned before, is not allowed. It's strictly forbidden because of the spread of the disease. In collaboration with our pathologist, we have, like, when we have our pathology report, we can see if our lymph node dissection is radical. When is it radical? So we have minimum of 15 lymph nodes extracted in the neck area, minimum of 10 lymph nodes extracted in the axillary dissections, and minimum of 5 lymph nodes extracted in the inguinal dissections. What are the indications for the lymph node dissection? It is the positive sentinel lymph node biopsy, as I mentioned before, and positive lymph nodes diagnosed clinically by fine needle aspiration biopsy, and of course with ultrasonography, CT scans, and other means of diagnosis. What are the complications? The complications of the lymph node dissection is lymphedema, nerve injury, and wound infection. And of course, there is the risk of local recurrence, because even the best lymph node dissection does not completely exclude the possibility of disease recurrence, as I will show you in my clinical cases afterwards. After the lymph node dissection, adjuvant therapy and immunotherapy or targeted therapy is recommended to target the residual disease and to reduce the risk of recurrence. And of course, the BRAF mutation is required for diagnosis in the lymph nodes. So this is one case that I will show you with stepwise diagnostics and treatment. So he had a melanocytic lesion on his abdominal wall that we did diagnostic excision. The pathology reports came back with the Breslov stage 5. In this case, we did a sentinel lymph node biopsy that showed the sentinel lymph node in one of the in the left axilla, I think. So we did re-excision and sentinel lymph node. The results show that he has micrometastasis in his lymph node. So we had a pathology TNM staging of stage 3C. Afterwards, we did axillary lymph node dissection, and there was no further lymphatic spread. As you can see here, I think that we extracted around 23 lymph nodes, so the dissection was more than radical. And this patient receives immunotherapy, and after 5 years, he doesn't have progression of his disease. This is a very interesting case of a young boy. He was 19 years on when he was diagnosed with vanishing melanoma. Actually, this boy was referred to the plastic surgery department because of recurrent submandibular sialoadenitis. He was treated 1 year before for sialoadenitis. Basically, they were treating the boy for metastatic disease in his neck, unfortunately, from this small lesion on the cheek that he has it's marked with the arrow. So we did the excisional biopsy. We had the report of vanishing melanoma. Because this boy was young, we did the most aggressive surgery that can be done for this patient. We did white excision with 2 centimeters of margins on his cheek, as you can see. We did superficial parotidectomy with facial nerve preservation, and we did radical neck dissection. And this was the pathology report. So he had metastasis in his neck and in his parotid gland, and he started immunotherapy, and with our good collaboration with our oncologist, the patient came to see me last week, and he is 5 years disease-free. And as you can see, he doesn't have any problems with his facial nerve, and his scar on the face is and on his neck is very good. The next case I want to present is this melanoma on the posterior side of the leg of a patient, and positive lymph nodes on his positive inguinal lymph nodes that we did a white local excision with flaps closure and radical lymph node dissection of his inguinal region. But in life things get complicated. We got this result: the melanoma in his leg and the lymphadenitis chronica in his groin. So what did I do? I asked the pathology report to be to redo the lymph nodes, because I was sure that I saw the metastases because they're black, and I got the same result, that it was lymphadenitis chronica and sinus histiocytosis. It was COVID time, and the patient didn't go on regular follow-ups, and this is one famous quote: "Who are you going to believe, me or your own eyes?" I believe on my own eyes. So 2 years I sent the patient to oncology department to receive the adjuvant therapy, but The oncologist refused to do it because his stage was stage 2, and after 2 years he comes back like this. As you can see, he has metastasis on his incision line for the inguinal lymph node dissection, and in transit metastasis here on his posterior thigh. What did we do? We did excision of both lesions, and the patient, of course, this time had melanoma in his inguinal region and in transit metastasis. Now he's on immunotherapy, and the patient is disease-free for 2 years now. What about the surgery of metastatic disease? So in transit metastatic disease includes any skin or subcutaneous metastases that are more than 2 centimeters from the primary lesion and they're not beyond the regional lymph node basin. Satellite metastases are defined as lesions occurring within 2 centimeters of the primary tumor. In the absence of distant metastatic disease, surgical excision is the treatment of choice always when feasible. And the margin of this, when we excise this lesion, shouldn't be that wide as we do with the primary lesion. So complete resection of metastatic disease is associated with prolonged survival up to 40% of the cases. And symptomatic lesions also should be appropriately resected in palliative setting, even when the life expectancy is short. So these 2 cases, I kept them for the end. So this is a patient with metastatic disease of unknown origin. I was called in the OR in the thoracic surgery. So they excised this tumor that was like both metastatic disease and progression from the primary tumor. Why? Because as you can see here, I don't know if you can see well on the picture on the bottom right, he had a small scar, like 3 centimeter scar. Some surgeon in abroad excised the lesion and didn't send the lesion to pathology report. So that lesion, we didn't see it at first, but when we got the pathology result, we realized that it is a melanoma, and the melanoma spread to his lymphatic lymph nodes. Unfortunately, this patient passed away due to metastasis in his brain. This is also an example of excision of metastatic melanoma in the lumbar region. So you can see we can excise very big lesions and still reconstruct them in order to patients to have a very good quality of life. So in conclusion, the surgical treatment of melanoma represents a cornerstone in the multidisciplinary approach to managing this complex disease. However, surgical management is only one aspect of the comprehensive melanoma care. The prognosis, surveillance, and the adjuvant therapies are equally critical components in optimizing patient outcomes and survivorship. Advances in immunotherapy, targeted therapy, and personalized medicine offer new hope for patients with advanced disease and high-risk features. It is essential to prioritize early detection, individualized treatment approaches, and ongoing research efforts aimed to improving the therapeutic options and patient outcomes. And once more, I'd like to emphasize the collaboration between the surgery, dermatology, pathology, nuclear medicine, oncology, and all other specialities that we fight a very difficult disease. Thank you very much for your attention.
Thank you. I'm generally opening a discussion because we have 3 presenters, so any questions, dilemmas.
I would like to ask Dr. Bisara, why is it so important to do the right excision as early as possible, and maybe sometimes if the diagnosis of melanoma is not suspected, and you have the margins are clear and it's all fine, why isn't it possible to do a later right excision? Because we had a case like that.
Well, these are recommendations by European societies of NCNS because of they do large cohort studies of the spread of melanoma. So the recommendations now are maximum 4 weeks from like when we get suspicious lesion to excising the lesion, and I think it's 2 to 3 weeks for the pathology report. Am I correct? Something like that. Yes, in order to get the more. Yes, because why is it important? Because melanoma, as you know, when it's confined to the skin, it's a local disease. But when it starts spreading, it's a systematic disease, and then the surgery is only.
What about superficial spreading melanoma, melanoma in situ?
When we do the diagnostic excision, we do the margins 2 to 5 millimeters. If it's melanoma in situ or a melanoma like superficial spreading melanoma, it's a curative excision. So 5 millimeters is enough for melanoma in situ. So that's why we do the margins of 5 millimeters. It's enough also for.
I understood, but my question was regarding non-suspicious lesion that was answered as a melanoma in situ or superficial spreading melanoma.
These guidelines are when we referred patients with suspicious lesions for melanoma. We are referred for basocellular, all other lesions, but when we have very good collaborations with our colleagues from venerology, so they send us everyday patients with suspect lesions for melanoma, and we excise them. And we gave them back the pathology report because they need to compare their finding in dermoscopy and pathologic. So it's very useful for them also to increase the specificity of the dermoscopy. So it's very important to collaborate and to have communication between the surgeons and the dermoscopists, because we also gather data and we compare the dermoscopy results, the pathology results, and afterwards with the oncology, the survival rates, the sentinel lymph node. So we do a lot. We have a big database that we are doing right now. So we can find the optimal way for managing these patients.
Yes, just a comment for dermatologists, for Dr. Silvia and Dr. Zorica. The question is that can their expertise or their measuring the depth of the lesion can assist you, or maybe to predict how large the resection will be, let's say?
We only, right now, the only thickness that we measure is the Breslau thickness that is confirmed by pathologists. So we have like the pathology results, and it's very precise, the depth of the tumor, and when the depth is like, we have like these guidelines, we excise if needed. Sometimes it's not needed. Yes, sometimes. Okay. But for example, even I, after very local experience in excising lesions, sometimes I do wide excision because I suspect that it's a very high risk lesion. But as I showed you before, it's better to do the diagnostic excision first than to do the wide excision, because sometimes even the most suspicious lesions for melanoma can be pigmented basal cells or hemangioma, and that happens in reality. That happens.
In our reports, Rabateva?
Yeah, this is for Teams.
Okay. In our reports, we make morphologic diagnosis. We don't measure, we can't measure the depth, but we describe, we put the diagnosis morphologic, and sometimes we describe the dermoscopic structures, and maybe this is enough for the prediction for preparation for a surgical part. Yes.
Okay, thank you.
Yes, every pigmented lesion we take it very seriously, and we excise it and forgo with other diagnostic procedures that are required, the staging and afterwards if necessary.
So our next is presenter is. Okay. Yes. Samira, you want?
I'm Dr. Amina Elhouch, I'm coming from Clinical Center University in, I think I'm loud now.
No, this is for Teams. For the Teams.
Clinical Center University in Sarajevo. Thank you for great lectures, all three of you. Just a little comment, I'm a medical oncologist, so the case that you are presenting with the melanoma on the leg and metastatic disease on the neck, without metastatic disease and the inguinal, and I'm sure that oncologists didn't give any adjuvant treatment, because it's not about stage 2 melanoma, because that's stage 3. I think it was in the era of COVID, that is the era that adjuvant therapy wasn't reimbursed. So I think that that's the reason. I have to defend the oncologists. So
No, we had probably the.
Ask you about your experience with head and neck sentinel lymph node biopsies, because I know that they are very tricky. Our plastic surgeon doesn't do the head and neck, only maxillofacial surgeries. So this presentation was really impressive. That's your experience.
Thank you so much. So, sentinel lymph node biopsy is very tricky in head and neck, and it's the sensitivity and specificity level is lower because the spread is it can go in several ways. When we treat melanoma on head and neck, especially in young patients, because I don't know why younger population have melanoma on head and neck, we are very aggressive. And sometimes we do prophylactic lymph node dissections and superficial paroidectomies because of this diagnostic error that could happen with sentinel lymph node biopsies. We had cases with very young patients that in COVID era we were unable to do the superficial paroidectomy and the neck dissection, and they developed positive lymph nodes in 2 to 3 months. So the spread in head and neck is very, very fast, and it's usually very aggressive, and it's very difficult to treat. But these patients that we already have, they have.
He's going well.
They're going very well because of the radical surgery
adjuvant treatment
and the adjuvant treatment. So yes, that was the case, and I showed that case because that case we also have to show our mistakes that we do and to talk about them openly, because this patient with the inguinal lymph node, he had positive metastatic disease. That's why we did the inguinal lymph node. But what happened afterwards, I cannot explain. It was miscommunication, bad luck sometimes. But now the patient is going well because we are treating together with Igor, and he is very. He's stage 4, but he is very excellent with the targeted immunotherapy. Thank you very much.
Thank you. We should make now, I think. So we'll continue with assistant Panče Zdravkovski. We will speak about pathological interpretation of the prognostic markers, and after that we can break. Okay.
Distinguished guests, dear guests, distinguished guests from abroad, from behalf of Dr. Boro Ilievsky and myself, I would like to express my gratitude to Professor Stojkovsky for giving this excellent opportunity to be part of this cost-action immunomodel. So I will present a subject which contains pathology and interpretation of prognostic markers in advanced melanoma. I have no conflicts of interest to declare, so when we speak of melanoma and pathology and tumor in general, we always start to our pathologist Bibles, that's called the Blue Book, so the WHO, World Health Organization, a classification of skin tumors, which last edition was published in 2018 by the International Agency for Research on Cancer. And that book, it reflects the view of a working group that convened for a consensus and editorial meeting which happened in 2017. So the Blue Book classify melanomas in different categories, so pathologists and clinicians also recognizing most of these types and subtypes of melanoma, but there is a difference between in the categorization of the melanoma. So there is a category of melanocytic tumors which arise in intermittently sun-exposed skin. That's the low CSD melanoma and or the superficial spreading melanoma, which we mentioned before. So there are tumors which appear in chronically sun-exposed skin. Also, thank you. The melanocytic in acral skin, in genital mucosa. So these are all types which we already mentioned in the previous lectures. So what's the difference? The WHO introduced a new term which called CSD. That's a cumulative sun damage. So now the melanomas are categorized considering that fact. So the multidimensional pathway classification of the latest Blue Book is based on the role of the UV radiation. UV radiation, the cell or tissue on origin, or specific characteristic recurrent genomic alteration. So in biopsies, UV radiation exposure is assessed in terms of solar elastosis as a measure of cumulative sun damage. So there are three grades of cumulative solar elastosis. Grade 1 is the smallest and grade 3 is the highest. So this classification divides melanomas arising in sun-exposed skin and melanomas arising in sun-shielded sites or without known etiological association with UV radiation. So before I proceed, I need to clarify and mention these terms regarding to melanoma progression. So the RGP, or the radial growth phase, is an atypical melanocytic proliferation confined to the epidermis and superficial dermis, meeting the criteria for melanoma, in situ or invasive, but lacks the vertical growth phase. The vertical growth phase is a melanocytic proliferation in the dermis characterized by expansile growth or tumorigenic proliferation and or mitotic activity meeting the criteria for melanoma. So the pathologists and also the clinicians knows these two next entities, the SEMPUS and MELTAMP. SEMPUS is a superficial atypical melanocytic proliferation of uncertain significance. It's an atypical proliferation confined to the epidermis or superficial dermis with features insufficient for definitive diagnosis but not ruling out the radial growth phase. Malignancy lacking the tumorigenic vertical growth phase. And the melanocytic tumor of uncertain malignant potential, it's a proliferation in the dermis that is tumorigenic but lacks the specific criteria needed to distinguish between benign and malignant proliferation. Also, a prognostic classification which was proposed in WHO, that kind of a classification can be assessed in terms of prognostic attributes. So those attributes were given and proposed in the American Joint Committee of Cancer and the Union for International Cancer Control staging models. So they include tumor thickness, ulceration, presence of satellites, and mitotic rate. Also, they include the tumor infiltrating lymphocytes, lymphovascular invasion, perineural invasion, regression, Clark's level of invasion, and lesional location. So localized primary melanomas confined stage 1 and 2. Regional metastasis defined stage 3, and non-regional metastatic disease is stage or disease. Stage 0 constitute melanoma in situ, which generally do not have capability of metastasis. So I will say a few words about the most common melanoma types according to the WHO Blue Book. So first is the melanocytic tumor arising intermittently sun-exposed skin. That is the low CSD, so low cumulative sun damage melanoma. That's the superficial spreading melanoma. It contains a pegyatoid or lentiginous intraepithelial components. It appears in lightened skin people which have repeated sunbursts in the childhood and also have intermittent sun exposure throughout life. So it happens in people, especially in women who underwent in tanning beds, and it can appear on legs, backs and shoulders. So it starts as a pigmented macule with an irregular outline, which can develop to papule and plaque with poorly defined borders. It can have a variable pigmentation. It can also show regression. The pegyatoid pattern of melanoma in situ is an intraepidermal proliferation of individual cells at many levels of the epidermis and variably sized nests across the dermoepidermal junction. The lentiginous pattern of the invasive low CSD melanoma is predominant with smaller nests with less or no pegyatoid scatter. Differential diagnosis of this type of melanoma is pegyatoid disease, carcinoma in situ, or schistoid neoplasm. So this is a nice histological representation on how superficial spreading melanoma look like. Lentigo maligna melanoma is a chronically sun-exposed skin melanoma. So it is happening on a skin with a high degree of CSD, so high degree of solar elastosis we can see in these patients. So lentiginous in situ component, also called lentigo maligna, with the proliferation of mostly single cytological atypical melanocytes in the basilar epidermis. It appears in older population with chronically exposed sun skin, head and neck region. It starts as a radial growth phase, as a plaque or a patch, which can thicken, which can endure, so it can become a palpable and visible nodule. Histologically, it has indefinite borders with an epidermal thinning and loss of retinal ridges, and by basal lentiginous rather than pegyatoid proliferation of atypical melanocytes. So there are two patterns. So there's a pattern, classic lentigo maligna pattern, is a broad lesion with a continuous proliferation of uniformly atypical nevoid to epithelioid melanocytes, and the lentigo maligna and dysplastic nevoid lentigo maligna and dysplastic nevus-like lentigo maligna pattern. Differential diagnosis of this tumor are solan lentiginous, dysplastic nevus, and actinic keratosis, which are diagnoses which one pathologist can diagnose in the daily diagnostic practice, seeing the skin biopsies. So this is a nice histological representation of invasive lentigo maligna melanoma. So on the right side we see the lentigo maligna, that's an in situ component. On the left side we see the invasion in the dermis. Desmoplastic melanoma, it is a spindle cell melanoma variant. The characteristic is that malignant cells are separated in between malignant cells. There is a collagen fibers and fibrostroma. So 1 to 4% belong to this kind of melanoma at the age of 65 years old. It happened on the sun-exposed skin, so chronically sun-exposed skin with a high CSD level. Head and neck regions, it starts like an indurated plaque, or it can look like scar-like thickening on the skin. So one of the most important features of desmoplastic melanoma, so most of the lesions do not have a pigment, so almost half of the lesions are not pigmented. So it's a paucicellular spindle-shaped melanocytes histologically. The tumor cells look like fibroblasts because they lack pigment. And in between there is a fine sclerotic or mature collagen bundles. Stroma can be fibromyxoid, overlaying epidermis is usually thin and atrophic. Differential diagnoses are many in desmoplastic melanoma, so every pathologist needs to be very careful in diagnosis. So there is a desmoplastic nevus, desmoplastic Spitz nevus, sclerosing cellular blue nevus, immature scar, dermatofibroma, sarcoid carcinoma, leiomyosarcoma, and others. So this is a classical histological appearance of desmoplastic melanoma, where we can see paucicellular neoplasm in between, and you see the collagenous stroma. Spitz melanoma, this is one of the special, more rare types. It calls malignant Spitz tumor or Spitz melanoma. That it exhibits the morphological feature of a common Spitz nevus, but sometimes it can be indistinguishable from atypical Spitz tumor. These lesions can have a diameter more than 1 centimeter. That goes to melanoma diagnosis. So less than 1 diameter, it goes to atypical tumor and Spitz tumor. So histologically, we can see effacement and consumption of the epidermis, ulceration, asymmetry, enlarged, irregular, and confluent nest and pegytoid scatter. Acral melanoma, this melanoma type appears in glabrous acral skin on palms and soles. Possible role of pathogenesis could be physical stress, pressure, friction, maceration, irritation, and the most common histological subtypes are acral lentiginous melanoma, followed by nodular and superficial spreading melanoma. Mucosal melanoma, genital, oral, or sinonasal, they're diagnosed in 0.03% of all cancer diagnoses with no apparent association with UV radiation. Interestingly, these types of melanomas are almost always pigmented lesions, so they 85 to 90% are pigmented. The most common patterns are mucosal, lentiginous, and nodular melanoma. Histologically, they're epithelioid or spindle-shaped melanocytes with amphiphilic or eosinophilic cytoplasm with variable pigmentation. This is histological representation to micrographs from melanoma rising in blue nevus, where you can see a part of the blue nevus, and on the right, on the lower picture, you can see the melanoma. So it arises from the blue nevus lesion. The nodular melanoma is the most invasive and tumorigenic primary cutaneous melanoma, arise from a pre-existing radial growth phase proliferation of atypical melanocytes in the epidermis and superficial dermis in the overlying and or flanking skin. This is a histological representation of nevoid melanoma, so this is very nice for pathologists also to refresh the knowledge about how it looks. So this was the first part where I will finish with the pathology part, and now the second part I will speak about prognostic factors and markers for melanoma. So prognostic factors can be divided tumor-related and host-related. I will say a couple of words of tumor-related prognostic factors. So the tumor thickness measured by Breslow. The thicker tumors generally indicated poorer prognosis. It is measured, the thickness of the tumor, it is measured from the top of the granular layer of the epidermis to the deepest invasive cell across the broad base of the tumor. So if the tumor is ulcerated, the measurement is happening from the base of the ulceration to the deepest melanoma cell. Mitotic rate is no longer used in a T category criterion, although it remains a major determinant of prognosis. It should be assessed and recorded in all primary invasive melanomas. Ulceration represents a full thickness absence of an intact epidermis with associated host reaction above the primary melanoma, and is the second criterion for determining T category. The tumor-related prognostic factors is also extent of metastasis. Usually conferential neural invasion, and within the nerve, so intraneural invasion. From the host-related prognostic factors, we need to mention the tumor infiltrating lymphocytes, the TIL. The presence and activity of these kind of lymphocytes within the tumor can indicate a better prognosis to immunotherapy and improve prognosis. Regression is a phenomenon where a previously pigmented lesion loses its coloration, becoming lighter or even devoid of pigment. Also can manifest as a reduction of size and thickness of the lesion, and the regression is associated with better prognosis. Patient age, older age in patients is often associated with worse prognosis. And location and size of primary tumor also is important. So tumors located in certain areas of the body may have a worse prognosis, and larger tumors generally have a poorer outlook. And the prognostic markers, their molecular and immunohistochemical marker, BRAF, NRAS, c-KIT, and PD-L1. So BRAF, approximately 50% of all melanomas have mutation in the BRAF gene, particularly codon V60 mutation, often associated with younger age at the diagnosis, a higher frequency of tumor mitosis, and a higher likelihood of developing atypical or aggressive subtypes of melanoma. BRAF mutations drive the abnormal activation of the MAPK signaling pathway, which promotes tumor cell proliferation and survival. BRAF inhibitors inhibit the mutated BRAF gene protein and can lead to significant tumor shrinkage and improve outcome. When combined with MEK inhibitors, BRAF inhibitors can further enhance treatment efficacy and delay the development of resistance. Some patients do develop resistance to these drugs, so BRAF inhibitors may affect the tumor microenvironment and immune response. So this is a molecular analysis which can be taught later in this workshop, and we report it as present or absent. The NRAS mutation present in approximately 15 to 20% of all melanomas, predominantly in cutaneous melanomas, which have high degrees of cumulative sun damage. Mutant NRAS protein exhibit constitutive activation of the downstream signaling pathway, including MAPK pathway. The aberrant signaling promotes cell proliferation, survival, and tumor growth. NRAS Q61 occurs in 90% of NRAS mutated melanoma, and MEK inhibitors have shown clinical efficacy for NRAS mutated advanced melanomas. So this is also a molecular analysis, and the mutation is reported as present or absent. c-KIT, or CD117, relatively rare mutation in cutaneous melanoma, but can be found in 10 to 20% of certain subtypes as acral lentiginous melanoma and mucosal melanoma. In mucosal melanoma, c-KIT mutation appear from 10 to 39, almost 40% of the cases. One of the most commonly used c-KIT inhibitor is imatinib, which was initially developed to treatment to chronic myeloid leukemia, which also has shown efficacy in melanomas with c-KIT mutations. And the last, PD-L1. PD-L1 expression on tumor cells allowed them to evade immune surveillance by binding to PD-1 on T cells and inhibiting their activation and effector functions that can evade destruction by the immune system and promotes tumor progression and metastasis. PD-L1 expression has emerged as a predictive biomarker for response to immune checkpoint inhibitors such as anti-PD-1 antibodies and anti-PD-L1 antibodies. Assessment of PD-L1 expression is done by immunohistochemical staining of formalin-fixed paraffin embedded tumor tissue. So we measure the staining intensity qualitatively, so 0 is negative, 1+ is weak, 2 moderate, and 3 strong. We need to count a minimum of 100 viable tumor cells and determining the percentage of partial or complete circumferential plasma membrane linear staining at any staining intensity. So in these three micrographs, we see the immunohistochemical staining for PD-L1. On the upper left corner, you see the absent PD-L1 expression, so is reported like less than 1% expression. The second micrograph on the right side, that's partial plasma membrane expression in cells more than 1%. Viable cells, and the third one is a complete linear plasma membrane staining, so it's reported like more than 5% of the tumor population of the viable tumor cells. So because this was my last slide, closing message, I need to say that together, through our collective expertise and commitment to collaboration, we can advance melanoma care, improve patient outcomes, and ultimately work towards a future where melanoma is no longer a life-threatening disease. So I would like to thank you for your attention.
So actually, when we are looking at the PET-CT scan, we are looking to the glucose metabolism. And here I present you the normal biodistribution. It's also important to know it. So every tissue, every organ that utilizes a lot of glucose will be seen in this scan. So you can see the heart, you can see the brain with a lot of uptake, liver here, and also brown fat tissue as well. Why PET-CT in advanced melanoma? It's perfect and the best for distant metastasis. And of course, when we perform PET-CT, we can see the whole body, and we can evaluate the whole body for metastasis in one act. Of course, nothing is perfect because the high FDG uptake in the brain that I've mentioned previously. The method is not useful for brain metastasis. We can see them, but magnetic resonance can see them better. So it's not used for the brain imaging. Although we do include the brain in our protocol, in our standard protocol for scanning. And of course, there is a problem with very small pulmonary metastases that are less than 10 millimeters. They're better defined, but by contrast-enhanced CT. And as you can see on other slides down here, for bone, of course, musculoskeletal, distant metastasis, PET-CT is much better. Do we use functional imaging and PET-CT in initial staging? Now, according to recommendations of ESMO and NCSN, it is useful to make initial staging with PET-CT and brain MRI in patients with stage 3 and higher of the disease. And also in high-risk patients, like patients with satellite or in-transit metastatic lesions or positive lymph nodes, sentinel lymph nodes. Aside from initial staging, also what we use FDG PET, of course, in advanced melanoma is early recurrence, assessment of treatment response, and PET-CT as a potential prognostic marker. And here we have one of our patients, our scans, where we can see only one lesion. So it is a follow-up scan that is used for detection of early recurrence. Of course, nothing else is seen, no pathologic foci otherwise, so we were puzzled what's happening. And we discovered that actually that's accumulation of FDG in the colon. So yes, bowel metastases are possible in metastatic melanoma, although not so frequently in the colon. We were not so hasty to report it as metastasis, so we wrote it down and suggested colonoscopy. And at colonoscopy, actually, it was polyp. So 2 centimeter polyp, not metastasis, but of course, highly suggestive of colon carcinoma. Unfortunately, we did not get the confirmation of pathohistology yet. Very important in functional imaging is therapy response, and therapy response with FDG PET and monitoring with FDG PET has become very important with the introduction of immunotherapy and, of course, targeted therapy. So here it is, one of our patients with partial regression, as you can see. So it is widespread metastatic disease, advanced melanoma. Here you can see the baseline scan before the start of the therapy, and still some of the lesions are active, but it is really a good response. And of course, there is always some problem. And when we are talking about the response criteria, well, they're still not very well defined at the moment. Many criteria for metabolic response, they are all in complete response. There is no doubt what is happening. Of course, complete regression of the FDG erythrocytes according to every criteria. But when we are talking about progressive disease or partial regression, then different criteria are used. So some criteria use SUV and the percentage of the diminishment of SUV or the increased SUV for progressive disease. Some of them are talking about SUV but normalized on lean mass. And also one of these criteria is immunopersist 5, is based on changes of the SUV, or actually of SUL, in 5 lesions. So can you imagine how that looks in a busy practice? I mean, when you have to do this and report it in this way, it's nightmare. So it's really not working in everyday practice like this. And one step forward that I liked personally, it's really this per-SMIT that is suggested and introduced by a group from Heidelberg. Nothing different in complete response, so it's like in every other criteria. Partial response as well, but they're very cautious in disease progression. So actually, few more small foci, actually 2 or 3, that are smaller than 10 millimeters is not progression according to this criteria. Also, 3 or more new functional lesions with functional diameter that is greater than 10 millimeters, also not progression. If you have only 1 new foci, even if it's larger than 15 millimeters, according to this criteria, also not a progression. Why is this important? Because if there is disease progression, you have to change your therapy. And the thing that is complicating the response evaluation in FDG PET with immunotherapy, of course, and targeted therapy is that very often we see pseudoprogression. Pseudoprogression because the immune system is activated. So here it is a case of one patient that had melanoma of the foot. And 3 months after baseline scan was completely clean. 3 months after PAD1 blocker therapy, peritoneal focus developed. So it is here on MEP scan, you can see it, and here you can see it in this coronal and sagittal projection. And it was not reported as progression, of course. After 6 weeks, control PET-CT demonstrated complete spontaneous regression. So it is very important to have in mind this pseudoprogression that occurs almost in 15% of the patients with that are receiving therapy with immune checkpoint inhibitors. And in other patients, it's estimated between 7 to 10% of the patients. And of course, you can have progression. I mean, here it is clear-cut progression, one of our scans, so the baseline the study on follow-up, and then afterwards progression after several months. When we are scanning with FDG, we can also see the therapy-related adverse events. So different therapies frequently can yield adverse events with bowels, adrenals, pancreas, lungs, hypophysis. So, for example, here is one adrenalitis, and here it is white arrows with where inflammation is. And of course, corticosteroid therapy was given to the patient, and that complication resolved. Sometimes, of course, if the adverse event is life-threatening, the therapy has to be stopped. Colitis, very suggestive pattern of string of pearls. That's very characteristic for this kind of adverse event in patients, what we see in colon. That is different from metformin accumulation in the colon. So besides that, we can monitor therapy response, we can also see the adverse events, and in that way help the clinician to guide the clinician in the treatment of the patients. And while we're talking about functional imaging, of course, a lot of people are talking about radiomics, and I think that tomorrow there is also, I've seen that there is one talk about artificial intelligence and deep learning, and I'm very fond of this topic, because at the moment at our institute we have one group that is working on this in radiomics, but not in melanoma, in hematology malignancies. It's not easy, it's quite controversial, a lot of problems when you are working with radiomics. To be honest, I didn't know what's happening with melanoma in radiomics, so I just went for this event, I went through the papers, and actually not much to be said in case of functional imaging, PET scans, said radiomics, very few abstracts, very few works. We all want to see prediction of therapy response, of course, with artificial intelligence, with predictive models, maybe virtual biopsy, but we're not there with malignant melanoma in regard to PET radiomics. So I think they're doing something a little bit better in imaging in CT and radiomics. There are some better studies at the moment. And of course, we want some prediction of the response in therapy. So baseline scan, FDG, one group researchers were doing pre-treatment FDG PET-CT to predict therapy response of immune checkpoint inhibitors. They used the standard parameters, SUV, volumetric also parameters like metabolic tumor volume and glycolysis, total lesion glycolysis. And actually, as you can see on these scans, here we have complete response, or maybe even better seen here. So there is a higher metabolic tumor volume here, and there is a tumor response. Patients that on baseline had very minimal tumor volume actually afterwards didn't have good response to therapy. So at the moment, nothing favorable in that area. And of course, I have to talk about new radiopharmaceuticals. I can't talk only about FDG. I mean, yes, we all use FDG here and everywhere in the world. It's something that is really very important for oncology patients, but it's not specific, we are just seeing the glucose metabolism. So new radiopharmaceuticals are developed, of course. And of course, in melanoma, it's very prudent to think and to target the melanin. So one new radiopharmaceuticals that has first results are very promising, and they are targeting melanin and labeled with F18. That is also very good from the standpoint of nuclear medicine. Something that is very actually, it's very fashionable maybe today, I would say. It's FAPI. So it's fibroblast activated protein inhibitor. So actually we are not looking at the tumor, but the environment, the microenvironment of the tumor. a lot of studies because at some points when the industry gets in, they're really promoting it, and there are a lot of clinical studies at the moment in different kind of carcinomas. So it is good as well in melanoma, in advanced melanoma. Why it is better than FDG? Because you can see also the brain, so you don't have to do FDG, you don't have to do MRI at initial staging, because there is no normal uptake in the brain. But of course, not everything is so good. It appears that it's not that good in the lungs. FDG is still better in the lungs. So here you can see the FDG scan in the same patient and FAPI scan. I think this is something that we will see in the future, and we will know the real indications for these radiopharmaceuticals in oncology. And of course, when we are talking about radiopharmaceuticals in nuclear medicine, now we are very fond of therapy and theranostics. So if you can put a diagnostic imaging isotope on something like FAPI, like gallium-68 now, of course, that you can put something that is therapeutic isotope that has alpha or beta emission. So that would be lutetium here, beta emitter. And there are also already studies in that regard, so to use FAPI as therapy. Because, if patients is progressing during chemotherapy or targeted therapy, then therapeutic options are limited. So, of course, there has to be something new. We like the concept of radiotheranostics. And at the moment, there are some studies with lead, also with gold, with copper, but still at the level of clinical trials, I'm afraid. And at the end of my talk, of course, I would like to invite you to the Balkan Congress of Nuclear Medicine that will be in 2 months here in Skopje. And if you want to know more about functional imaging in melanoma and in other oncological diseases, of course, half of our program will be oncology. I mean, welcome. Thank you.
So, thank you, Professor Glinska. I will announce the next speaker, and the discussion will be after this, after next presentation. Our guest from University of Sarajevo, Clinical Hospital in Sarajevo, Bosnia and Herzegovina, Amina. She will speak about neoadjuvant and adjuvant treatment strategies in advancement in melanoma. So just.
Hello. So first I want to thank you, Professor Igor, to invite me here. This is my first time in Skopje, and not the last time, of course. Thank you again. Today I will talk about neoadjuvant and or adjuvant immunotherapy in malignant melanoma. Last year was the year of lot of discuss about decision, is neoadjuvant immunotherapy enough? Can we de-escalate surgery? Can we de-escalate adjuvant therapy? In this year, we are not any smarter than the last year, and we will see why. So what do we know about neoadjuvant immunotherapy in resectable melanoma? We know that if we take the tumor out, we are taking it with its anti-tumor T cells. And if we take leave the tumor in, give some neoadjuvant immunotherapy, and then we are inducing clonally more diverse and numerically more anti-tumor T cells. And after that, if we take the tumor out, do the surgery, those higher numbers of anti-tumor T cells and more diverse anti-tumor T cells can go to attack micrometastatic disease. Neoadjuvant immunotherapy has many advantages. One of them is it can induce a stronger and broader anti-tumor immune response. And this presentation I will talk about another advantage, and that is the pathologic response and fast efficacy readout and surrogate outcome marker for survival. So the standard of care was you do the surgery and then give some kind of adjuvant treatment. But investigators ask themselves, what instead of just adding neoadjuvant immunotherapy, they ask, can pathologic response be used to treat patients differently? So they ask themselves, do all patients need extensive surgery? Do all patients need adjuvant treatment? And what is the best adjuvant treatment for those patients? So we heard a lot of times about this trial, that's Opasi-Neo. They gave neoadjuvant 2 cycles of combination of immunotherapy, did total lymphadenectomy, didn't get any adjuvant treatment, just follow up. And the other neoadjuvant trial is Prado trial. For me, this is fascinating trial because they marked the index lymph node on the patient, then gave neoadjuvant immunotherapy, and then do the surgery, just excited that index lymph node, and look what is the pathologic response here. For those patients who had complete pathologic response, the treatment was in that time ended. No extensive surgery, no lymphadenectomy, no adjuvant treatment. So I think that was really brave move. For the patient with partial response, they did only total lymphadenectomy, but without adjuvant treatment. And for non-responders, they did all extensive surgery plus adjuvant treatment. So they did post hoc analysis about those 2 trials. They divided patients in 2 groups, patients with major pathologic response and non-responders. And they looked at those subpopulations. In a subgroup of patients with major pathologic response, they analyzed those with extensive surgery and those without extensive surgery. And in a population with non-responders, they analyzed patients who received systemic treatment adjuvant and without any adjuvant systemic treatment. And they did all analysis. This was the last year's conclusions. They concluded that total lymph node dissection can probably be omitted in a patient with high-risk melanoma who achieve major pathologic response to neoadjuvant immunotherapy without affecting survival outcomes. But is it? We'll see later. Adjuvant systemic therapy improved survival outcomes for patients who achieved a pathologic non-response following neoadjuvant immunotherapy. And for the next presentation, they concluded that adjuvant radiotherapy may be beneficial only in a patients who are ineligible to receive adjuvant systemic treatment. For example, if the patient has high immunorelated adverse events, some kind of comorbidity, that they are not given chance to give us adjuvant treatment. The next trial that I want to talk about briefly is S1801 clinical trial. They enrolled 330 patients in 2 arms, adjuvant arm, standard arm, surgery, after that adjuvant pembrolizumab 18 cycles, and neoadjuvant adjuvant arm. They gave first 3 cycles pembrolizumab, then all the patients went under the surgery, and then they give 15 cycles of adjuvant pembrolizumab. The simplicity of this trial is that they just rearranged the sequence of events. They didn't escalate surgery and they didn't de-escalate adjuvant treatment. And the major point for our fonts, for our security, health and insurance, is that the number of the cycles of pembrolizumab was the same in adjuvant group and in neoadjuvant adjuvant group. Just the sequence of those 18 cycles was changed. So briefly, we can see here that event-free survival is statistically higher in the neoadjuvant adjuvant group compared to adjuvant group only, with a hazard ratio of 0.58. International Neoadjuvant Melanoma Consortium is a worldwide congregation of renewed melanoma investigators, and they gave some kind of recommendations what to do in neoadjuvant setting. On this slide, it seems really simple. You give some kind of neoadjuvant treatment, do the surgery, and give some kind of adjuvant treatment. So do we know how much neoadjuvant treatment from here to give? Do we know from this slide, when they pulled analysis of all neoadjuvant trials, they came to some mess. In some trial they gave just 1 cycle. In other trial they gave 3 cycles. In the third trial they gave 6-month neoadjuvant therapy. And more confusing is then when to do the surgery. We don't know, from this slide we don't know when it's time to do the surgery. And we don't know how many cycles of adjuvant treatment or how long adjuvant treatment should be we be giving. So how many doses of neoadjuvant immunotherapy, when to do the surgery, in how many doses of adjuvant immunotherapy. The next question is, you saw on that Prado trial, that index lymph node, their definition is that that is the largest lymph node assessed at baseline. So is it the largest lymph node, or is it easiest to mark? And who makes that decision? What lymph node is the index lymph node? Is the radiologist, oncologist, surgeon, tumor board? So we have a lot of dilemma here. It seems really simple, but it's not. Our colleagues from Netherlands and Australia looked at this a little bit carefully. So they made analysis of few trials and index lymph nodes, etc. And they noticed that around 30% of patients had 2 or more pathologic lymph nodes positive beside the index lymph node. And a third of these patients had slightly more viable tumor in non-index lymph node than in index lymph node. So interesting. So is the patient outcome driven by the last responding site? Exactly this question is led to Prado trial. So I talk about that, and in this trial they did the escalation of surgery depending of response on the lymph node. They did the escalation of adjuvant therapy depending on response in the lymph node, and we could give any kind of adjuvant treatment. It was investigator's choice. So these are the results that the first time that patients with partial response did worse than non-responders. Why? Because they needed adjuvant treatment. So, and the group of patients with major pathologic response, they had 4 relapses, and one of them with distant metastasis. And Prado trial planned to have no recurrences within 24 months, and they had 4 recurrences. So maybe in this subgroup of patients, total lymphadenectomy was the salvage therapy. When INMC pulled analysis from those neoadjuvant trials, on the left side you can see that is INMC analysis compared combination therapy with monotherapy in the neoadjuvant setting. And we can see from that slide, you you can think that combination neoadjuvant immunotherapy is better than monotherapy. But when you compare that to S1801, those data, and you can see that event-free survival in S1801 is 72% versus 59% in monotherapy, relapse-free survival in INMC analysis. And we have to remember that event-free survival will be lower than relapse-free survival because relapse-free survival starts at the time of surgery or adjuvant therapy, and event-free survival is counting all the early events that happened before the surgery. When we compare Prado on the left side of the slide and S1801 on the right side of the slide, we can see that those results are comparable. In the Prado, we had combination immunotherapy, just to remember, and in S1801, monotherapy pembrolizumab. We can see 72% event-free survival in neoadjuvant monotherapy versus 80% event-free survival in combo therapy. Just to remember, the toxicity of combination therapy is higher than in monotherapy. Overall survival, really similar results between combination in Prado trial and S1801 in monotherapy. So what about neoadjuvant nivolumab at relatlimab? So there was a small clinical trial, 30 patients enrolled. They gave Rela plus Nivo 2 doses neoadjuvant, then followed by surgery, and then 10 doses of adjuvant Nivo plus Rela. And what about those results? Is this combination better than the previous? We can see from here that event-free survival at 2 years was really similar. 81% combination Nivo-Rela, 80% Prado combination EP-Nivo, and 72% monotherapy pembrolizumab in S1801. When we compare combination therapy with monotherapy again, Nivo-Rela 88%, Prado combination EP-Nivo 85%, and monotherapy pembrolizumab in S1801 92%, similar. Now, these are the guidelines from this year, NCCN guidelines. So are we getting any smarter? No, they're giving us options. We don't have any guidance if we have patient who's eligible for neoadjuvant treatment. They gave us option to do the surgery, to give neoadjuvant therapy. Okay, we'll do neoadjuvant therapy. Which one? How long? We don't have answers yet. So if we somehow figure out what kind of neoadjuvant and how long, what in the adjuvant setting? How long? We don't have guidelines to state our what we think. So we don't have anything to rely on. And they gave us explanation. Optimal regimen and duration of neoadjuvant systemic therapy is not well established. So how to fix this? Can we fix this? Yes, we can. We can, for example, this is my example, we can create some kind of this trial. You have 3 groups, arms, standard of care, neoadjuvant mono, neoadjuvant combo, 2-3 cycles, nevertheless, surgery, then adjuvant, and then we'll have the real results. In conclusions, neoadjuvant immunotherapy is intriguing and prime times in some places. Unfortunately, despite best efforts, there will always be group patients that not get major benefit from neoadjuvant immunotherapy. So I'm not sure that we'll ever move completely from adjuvant treatment. Omission of total lymph node dissection and adjuvant systemic therapy is premature, but there are many trials that can be designed. Opportunity for surgery should not be lost in those resistant to neoadjuvant immunotherapy. The current randomized data support neoadjuvant plus adjuvant immunotherapy, and dropping adjuvant therapy may compromise outcome. Thank you.
For instance, how much can we predict with functional imaging, especially Melanoma? I mean, can functional imaging maybe replace sentinel detection? That's complete.
At the moment. At the moment, sentinel nodes are still the gold standard. But I don't know what will happen with new radiopharmaceuticals. That's something that we'll have to see what will.
I understand that we have immunotherapies. We have application of immunotherapy maybe relatively short period, 7-8 years. I don't know. Experience 10 years. But we do not have any conclusion when to give.
Yes.
And how long to give.
Yes.
And now plus, in addition, we have dilemma to begin before surgery, after surgery, how long after surgery. So I mean, for maybe.
Yes, but maybe in the future time, we'll have.
Question for the audience, cyber audience.
Okay.
In the teams, yes.
I don't know. 1 month ago, we were contacted by email to do the survey from Germans, Professor Axel Hauschild and his team, to give us our experience as a doctors, maybe about neoadjuvant treatment, what we think do we practice. Maybe on that survey from all the oncologists that he contacted, that was a huge list, maybe the European oncologists will make some kind of guidelines. In this time, we can go by our hint and do as in clinical trials, but yeah, it's not
But it's important to state that neoadjuvant is not approved generally, or according to
yes,
majority countries. Yes.
I would like to think like this. If you have inoperable or borderline operable patient, you can always give just one cycle of immunotherapy to induce those T cells to go to attack the tumor, and then send it to operation if it's some kind of extensive surgery. So that's my thoughts. But I'm. Okay.
Daniel.
I would just comment as a pathologist. Sometimes we're struggling with even dissected lymph nodes to find the metastasis. So when sentinel lymph nodes come into question, we have to perform serial sections and even stain immunohistochemistry on every 2 or 3 sections in order to detect whether there is either isolated tumor cells or micrometastasis or whatever. But the problem is when you get the metastasis larger than 1 millimeter, you have a problem. And it can differ the clinical guidance of this patient. I'm not sure how could an imaging detect 1 millimeter threshold of several cells, especially if we have into consideration that some of those, although metastatic clones, could be hypometabolic in a setting in a different microenvironment.
Ametabolic.
Or
yes.
Even worse, ametabolic.
Yes, we had a patient with ametabolic on the PET-CT, multiple lung metastases proven by pathology. They won't move from pathology. Pathology is stable. Surgeons are like a little bit.
I was just going to ask about your opinion and your comment about tumor-infiltrating lymphocytes in predicting the response from immunotherapy in neoadjuvant setting.
We know about papers that they are really reliable. Right now we are doing another regionally with Professor Kandolf and the other, like lymphocyte and neutrophil.
I'm sure is that the afternoon session about infiltrating lymphocyte and survival. I would like to make one general comment. Hello for everybody. My name is Vladimir. I'm medical doctor, a specialist in internal medicine, but I don't treat patients. I'm working 30 years ago for tumor diagnosis, particularly with melanoma. So, theory, it is better adjuvant surgery combination and base for many clinical experience. But generally, new period in medicine established with developed new market that will be potentially useful. This is also idea, but how to realize this idea is really so hard because metastatic process and involved lymph nodes and fourth stage of disease when we obtain is really complicated because many factors influence on spread of different cancer. Generally, so today is new period that we really look for molecular marker. But if you apply molecular marker, potential target, there is absolutely differently. If you apply one type therapy, second type therapy, or third type therapy, responders never respond better. I performed some analysis in Berlin, Germany, 30 years ago, and we're working in a cell line culture system. We treat with immunotherapy, radiotherapy, we transform gene therapy and apply, but every time is same situation. If we have resistant cell line, if you apply to patients, it is similar. If you have resistant patients, never achieve better response. This is formally and generally showing the big influence of genetics. So we have today probably aims in a science how to identify good markers. For example, PD-L1 is okay, is best marker that we have now, but cutoff is also problematic. We have positive 50% more and we have 25, maybe 5. In some cases we expect 50% positive marker is associated with good response, but we achieve good response with people with 5% or below 1%. Why is influence? Expression, gene analysis, protein involvement in this transformation process. So we really don't know how patients will be response. This is like to...
Okay, yes, it's mystery. Okay, we are... any questions?
This is my comment. But I don't work with patients and try to find a good market.
Treba se svrti na prema tabeli. Od Grčke
one question for the pathologist. How do you make difference or do you make in our institute different diagnosis between a typical Spitz nevus and Spitz melanoma? Is it possible? And do you work in... Because we know clinically and dermoscopically we have overlap for these two entities.
So those are the differential diagnoses which I mentioned in the presentation. So sometimes and always, like when we see in spitzoid neoplasm, spitzoid atypical proliferation, we need to be very careful in the interpretation. So the blue have criteria which are put in like you have Spitz tumor, atypical Spitz tumor, and Spitz melanoma. So Spitz melanoma is, I think, the least diagnosed version of these three spitzoid neoplasms. So we need to take care about the age of the patient, the size of the lesion. The size of the lesion is one of the top criteria for that. So the size that we measure, so we do the gross dissection, so we measure the size. So if those criteria follow like more than 80% of the lesion, even that it's in between lesions, so we think about spitzoid melanoma or atypical spitzoid tumor, we need to follow strict features. So I don't know if this answers your question, but we need to follow strict criteria. Yeah. So those specific are mentioned in the blue book, which I say. Yeah. So no markers. I mean, no immunohistochemistry. So that's a exclusively histological, histomorphological diagnosis. There is no marker that. Of course, you have marker which can like Milan A, HMB45, which can be that markers can show you where the melanocytes goes if there is an invasion. So if you have malignant melanoma, I mean malignant Spitz tumor, you can mark that. But in general, the morphology is like exclusively for these tumors. Yeah. So no marker for melanoma or a typical Spitzoid tumor.
Spitz tumor, Spitz nevus,
Yeah.
is very often in children,
Yeah.
but it's not the exception, the Spitz melanoma in children. Because of that, this is very risky.
Yeah, of course. I mean, we are very careful, so we consult. There are always 2 or 3 pathologists, always, when we have this kind of a lesion. So Professor Ivanovic maybe can add something to this subject to clarify this.
In practice, we usually have a conciliary look at the serial sections of this lesion, and then you try to find whether there is some lymphovascular invasion, which would favor a more invasive. Cases have been reported that sentinel lymph node positive in Spitz melanoma, classical Spitz melanoma, with no features of Spitz, no Spitz melanoma, but atypical Spitz tumor, or but already with a positive sentinel lymph node. We also, although it's not diagnostic, it can help if you perform the proliferation index in this tumor, see if you find some deregulation in the cell cycle regulators, like loss of function of some genes, or maybe aberrant or pathologic P53. And if you collect this data and accompany them with the morphologic appearance of the tumor, then it's more probable that you will get to the right diagnosis.
Okay, thank you. Thank you. Now we are finishing this. We have break. We are restarting in 2 p.m. So 2:05. We are starting the afternoon session, and our next speaker is Professor Roberto Diaz. He is radiation oncologist is coming from far away, from Moffitt Cancer Center and Research Institute from Tampa, Florida. So he will speak about radiotherapy and immunotherapy combination is in melanoma. So Roberto, floor is yours, please. I need to put the. Okay.
Thank you for the invitation, Igor, and it's a privilege and an honor to be here to talk about this important topic. Having been in Macedonia for over 5 years, and I used to come almost like twice a year before, but thank you. So let's get going. I have nothing to disclose related to this talk. In the United States, melanoma is important. You have over 200,000 new cases a year and over 8,000 deaths associated with it in 2024. 100,000, over 100,000 of these are melanoma cases, and being from Florida, second most number of cases with almost 10,000. As you can see here, some of the statistics in the United States. Melanoma specific survival by stage, as you obviously stage 1, 2, and 3. You can see that this is a very deadly disease if found at an advanced stage. But there have been significant improvements over the last 14 years. End-stage melanoma-specific survival, 3A, 3B, 3C, 3D. Obviously, 3D, they tend to do a lot worse than the others. So, related to my topic, why choose Nivo plus Ipi as first-line therapy? Overall survival, as you folks know, is 6.5 years. 49% were alive, and you can see here the progression-free survival and with Nivo and with BRAF mutants comparisons. So this comes from Checkmate 067 that shows the 6.5-year survival in melanoma, again putting Ipi and Nivo on the map for the treatment of melanoma. However, combining Nivo with Ipi is much more toxic than just Nivo alone. And this is something that you have more grade 3 or 4 adverse events, 6 times as many grade 3 or 4 adverse events, leading to treatment discontinuation from 30% to 5%. So let's now take a little parallel road to this, and that is radiotherapy. The vast majority of clinical data shows that radiotherapy is employed more for metastatic than for non-metastatic disease. Surgery obviously is the first choice of treatment for primary lesions, except obviously for select clinical cases like uveal melanoma. Due to the radioresistance of melanoma, very high doses of radiation are needed to obtain a complete remission. So, can we think of this in a different way? And that is radiotherapy. Can we use it to rev up or to increase the immune system against melanoma? So for the last 70 years, radiation therapy has been used, and this is what they teach us in radiobiology, usually is to target cancer cells, you damage DNA of the cancer cells, and I'm not going to go into a radiobiology lecture now about the 5 R's of radiobiology and things like that. But radiation therapies' beneficial effects on survival of cancer patients are due to local control of the tumor, directly decreasing the systemic spread. Nonetheless, experimental data from multiple cancer models now suggests that some of the effects of ionizing radiation are due to inducing systemic anti-tumor immunity. So recent examples of objective responses achieved by adding radiotherapy to immunotherapy in metastatic patients support this view. So the goal obviously would be to use radiation therapy with the immune system to extend survival even among metastatic and heavily pretreated cancer patients, and to combine radiation therapy with immunotherapies to turn the irradiated tumor into an individualized vaccine. So why combine immuno with radiotherapy? Radiotherapy, as I've mentioned, is rarely used to treat non-metastatic melanoma, while it does play an important role in metastatic disease. Melanoma is considered an extremely immunogenic tumor, and it usually presents a well-expressed lymphoid infiltration. Radiation can increase the tumor antigen's visibility and promotes the priming of T cells, and can also exert, on the other hand, an immunosuppressive action on the tumor microenvironment. So this is the catch-22 that we deal with. You are able to cause the tumor itself to be more immunogenic, but if there's any tumor infiltrates, radiation will wipe them out. Combining radiotherapy with immunotherapy provides an opportunity to increase that immunostimulatory potential of radiation. And the response to immunotherapy depends on the pre-existing tumor infiltrate and may be improved by radiation, which is able to activate this anti-tumor immune response. This is the disclaimer here. The factors influencing the final balance in this immunomodulation are mostly unknown. I mean, yet we see it even in clinical practice. But how or why this potential synergy of radiotherapy, and then, you know, when the tumor dies, it can release some neoantigens that then is able to have these antigen presenting cells, they engulf them, present them, and then you have specific CD8 T cells, then they're going to proliferate and then can go and attack the tumor. So that's a potential model. So radiation can cause an immunogenic cancer cell's death by releasing of this damage-associated molecular patterns like DAMP, such as ATP and the high-mobility group protein B1. Translocation of the cancer cell's surface eat me signal calreticulin promotes phagocytosis. Upregulation of MHC1 expression on the tumor surface increases tumor antigen presentation. In the cytosol, radiation-induced DNA fragments lead to activation of the STING genes, which then upregulate interferon type 1, activating the innate and adaptive immune responses. Radiation can also increase tumor antigens visibly and promoting the priming of T cells. But the role of the dose per fraction is also crucial. It's been shown that doses above 12 to 18 gray induce exonuclease TREX1 that attenuates the radiation-induced immunogenicity by degrading the cytosolic DNA. So there are some pathophysiological mechanisms that are varied behind this radiation-induced synergy, as I mentioned, including but not limited to increasing the MHC1, calreticulin, and fast cell surface death receptor, release of high mobility group BOX1 nuclear protein, activation of dendritic cells, enhanced tumor antigen cross presentation, increase in tumor infiltrating lymphocyte density, and modulation of immune checkpoint molecule expression and regulatory T cells. So one of the things that, as we're going to go into some studies that we have to keep in mind, is how we treat this metastatic disease. What is the endpoint that is being presented? Is it overall survival, progression-free survival, and response rate? So the challenge with the studies that some of them that I'll be showing is that how do you compare results from multiple studies? Many cases are just retrospective, assessing outcomes in patients with brain metastases. The type of radiation that was given, the dose of radiation, even within the same study, are different. The timing is different. So how do we interpret these results? So another challenge is that the primary and secondary endpoints between studies vary, with some studies evaluating certain variables and other studies evaluating others. And some examples of primary and secondary endpoints, as I mentioned, include overall survival, rates of radiation necrosis, local and distant brain mets, and neurotoxicity. Standardization of primary and secondary endpoints is needed. So there's studies out there that, and here's a table summarizing some of them, that combine immunotherapy with radiation therapy. And as you can see, most of them are retrospective in nature. In this review article, it shows them from 2013 to 2022. They use EPI, Nivo, or the other. And small number of patients, anywhere from 4 to 47. And then dose and fractionation of the radiation, as I mentioned, they do 30 gray in 10 fractions, from 12 gray in 2 fractions, 24 in 3. So there's a lot of variety, and in most of these cases are mostly metastatic disease. So here's one. They showed in this study that local tumor treatment in combination with systemic immunotherapy prolongs overall survival in patients with advanced melanoma. So in this case specifically, radiotherapy with ipilimumab improved overall survival. It was a retrospective clinical study. They tested the efficacy of the combination of local tumor treatment, whether it was radiotherapy or electrochemotherapy or selective internal radiotherapy, and IPI in 45 advanced melanoma patients. They considered subjects without CNS metastases. The overall survival was 117 weeks for those patients treated with IPI and local treatments versus just 46 weeks treated with ipilimumab alone. So the addition of radiotherapy to IPI allowed for better outcome irrespectively of local advanced stage or distant organ metastatic disease at their multivariate analysis. Again, very promising, but it's retrospective and it has a variety of ways that patients were treated. And so here is the table that showed the overall survival of being with the local treatment with a significant p-values, as you can see. Another study showed a dose escalation phase 1 study of radiotherapy in combination with anti-cytotoxic T lymphocytes associated antigen 4 monoclonal antibody IPI in patients with metastatic melanoma. So this one was actually a phase 1 study aimed to determine the maximum tolerated dose and safety profile of radiotherapy combined with IPI in patients with metastatic melanoma. It was a 3x3 escalation design, 9, 15, 18, and 24 gray, combined with IPI at 10 milligrams per kilogram every 3 weeks for 4 doses. The radiotherapy combined with IPI was associated with increased CD4 and CD8 T cells, and increased CD8 plus T cells was significantly associated with progression-free survival in this case. Now, when combined with IPI at 10 milligrams per kilogram, the MTD for the radiotherapy was the lowest. It was 9 gray. This combination of IPI and radiotherapy appears to be associated with anti-tumor activity, and increased CD8 positive cells was significantly associated with the progression-free survival. So these immune biomarkers may be useful for early response evaluation. And you can see here the toxicity profile. Again, it's a phase 1 study showing that why they chose the level 1. Once again, it's prospective, a very small number of patients, only 13 patients in dose level 1. And then by the time they got to dose level 2, you were seeing significantly higher number of adverse events. Want to be mindful of time, so I'm going to try to move quickly. I do have a lot of slides. When you think of melanoma, radiation, and metastasis, we all think of brain. This is where we in radiation oncology are busy. Again, not to say that it's exclusive for brain, but a lot of the studies and the work have been done with brain. So local treatments are key for brain mets due to the blood-brain barrier. So if you have 1 to 4 metastatic lesions, patients can be treated with surgery or radiosurgery. 5 to 15, this is now between radiosurgery or whole brain radiation. If you have more than 15 lesions, you treat them with whole brain radiotherapy. At least this is how we do things in the States. Don't know how they do things in the Balkans. So brain mets occur with an incidence, as you can know, 10 to 40% of advanced stage melanoma, and it's what accounts for death anywhere from 20 to 54%. The standard of care, as I mentioned, remains resection if it's a large symptomatic lesion, or radiotherapy followed by systemic therapy. Radiosurgery allows for a local control rate up to 90% and median overall survival from 5 to 11 months. Now with the introduction of IPI, the interest about synergistic effect has increased because local radiation could increase the permeability of the blood-brain barrier, therefore more of the immunotherapy can get in, prime anti-tumor immunity through release of tumor antigens, as was mentioned earlier, and alter the tumor pro-inflammatory microenvironment. Now, there's PD-L1 expression in melanoma brain mets. That's been shown that PD-L1 expression was noted in 22 out of 43 antiles and 39 out of 43 melanoma brain mets in this study. So you folks probably, I know that you guys know, immunotherapy alone for brain mets has been shown to be effective. Brain mets response to immunotherapy appeared to mirror systemic response rate. This was shown in the Checkmate 204 study. The combination of nivo plus ipi showed a 36-month intracranial rate of 54% with a 33% complete response intracranially, just with nivo and ipi. So symptomatic brain metastases continue to pose difficulty with immunotherapy alone because the 36-month intracranial rate was 19% for symptomatic patients. Can we do better? So can we combine systemic therapy with radiation therapy? So the blood-brain barrier can pose a challenge to entry of drugs into the nervous CNS. Studies suggest that the opening of the blood-brain barrier with receipt of whole brain radiation or stereotactic radiation therapy with an optimal window could be about 1 month post-treatment. So one of my colleagues who's now at Moffitt, in his previous institution, this is Dr. Evan Wuthrick, who's also specializes in radiation and melanoma at Moffitt. He worked in a phase 1 study of IPI combined with whole brain radiation or radiosurgery for melanoma patients with brain mets. So it was a prospective, 2 arms, whole brain radiation versus SRS. IPI, as you can see, is a lower dose. The low dose is 3 milligrams per kilogram. Is there a DLT? You lower it. If not, go ahead and increase to 10 milligrams per kilogram. So who received whole brain, who received radiosurgery? Here are the parameters. Running out of time. Dose of radiation for whole brain was 37.5 in 3 weeks, and the dose of the radiosurgery depended upon the size of the lesion. Here is how it was administered, the radiation and the immunotherapy. Again, it was a 3x3, 3+3 dose escalation design. Primary objective to determine the MTD of IPI when combined with whole brain or SRS, and to determine the phase 2 dose of IPI with whole brain or SRS. So what did they find? The median progression-free survival and overall survival in the whole brain radiation was 2.5 and 8 months, and in the SRS was 2.1 and not reached. So you can see the comparisons here with the whole brain being in the dashed lines and SRS solid lines with better overall survival in this cohort. Now, they found that concurrent IPI at 10 milligrams per kilogram with SRS is safe. No patients developed grade 4 or 5 toxicity. Median progression-free survival and overall survival in the whole brain arm was 2.5 months and 8 months, and in arm B was 2.1 as mentioned. Whole brain was closed early because of slow accrual, but demonstrated safety, and no patients experienced DLT. Larger studies, including those with combination checkpoint inhibitors and SRS, are warranted. In that study, they also had a nice table that showed other studies that showed melanoma brain mets treated with immunotherapy and SRS. And Igor, you only gave me 20 minutes. I can't cover everything. So I just giving the reference if you want to study more. Fresh off the press, my colleagues at Moffitt just published this study in the Journal of Neuro-Oncology on clinical outcomes of melanoma brain mets treated with nivo and IPI alone versus nivo and IPI with SRS. So this just hot off the press. I know everyone on the list except Joseph Tang. He must be the medical student. So results, 25 out of 74 melanoma brain mets received immune checkpoint inhibitors alone, and 24 patients with 84 lesions received concurrent SRS, median follow-ups of 2 years. They found no difference in the age, presence of symptoms, prior directed therapy, or SRS size, number were seen. So SRS group had a lower rate of grade 3 and acute toxicity, though this did not reach statistical significance. And the SRS group experienced more intracranial acute grade 1 or 2 and grade 3 toxicities, though there were no cases of grade 4 intracranial toxicities. The median follow-up was 2 years. For the entire cohort, at the 1 year overall survival, distant intracranial control and local control, as you can see, were 71, 57, and 78%. And there was no significant difference in overall survival between the two groups or distant intracranial control. But the SRS group did have improvement in local control, superior. So here are the some of the results running out of time. Results. Univariate analysis, it was the receipt of the combination that significantly predicted improved local control. So this retrospective single institution study is the first series to date comparing outcomes in active and untreated metastatic melanoma brain metastasis managed with upfront nivo and ipi alone or with SRS, and it suggests that the combo is well tolerated, no increased toxicity over nivo or ipi alone. To compromise systemic therapy course completion, inclusion of SRS was associated with improved local control, and this study is one of the few investigating melanoma brain mets treated with nivo and ipi and SRS, and of course it requires prospective validation, which may come from currently enrolling. There's a phase 2, the ABC-X study that randomizes patients with asymptomatic untreated melanoma brain mets to ipi and nivo alone versus ipi and nivo with SRS. So can be given without added toxicity. This combination of all three, no difference in overall survival or in the distant intracranial control were noted. However, lesions treated with SRS had better local control. So obviously further prospective study of the combination is warranted. So many studies about synergy between SRS and targeted therapies and melanoma brain mets have been reported. And if you can't read it, it's because I do not intend you to read it. We don't have the time for that. Of course, the question is efficacy, what about toxicity? So retrospective studies have questioned whether there may be an increased risk with combination of immunotherapy and SRS. This study of 115 patients receiving immuno with SRS and 365 treated with SRS alone revealed a significantly higher risk with immunotherapy, potentially higher risk with anti-CTLA4 over anti-PD-1 inhibition. But a multi-institutional study of SRS combined with immuno did not reveal an increased risk in 203 melanoma brain met patients. Rates were 9.4 versus 8.2% in the concurrent and non-concurrent group. So we need to distinguish asymptomatic radiation necrosis from symptomatic and improve the overall survival of immunotherapy. So brain mets, some results can be contradictory. Some studies have reported benefits to overall survival, local control in patients who receive immunotherapy with radiation, with a prognosis becoming at least similar to that of patients without brain mets. And I'm just giving some of the references. Some other studies have shown no difference in terms of local control or overall survival. Others reported a survival benefit in case of radiosurgery before IPI. And regarding toxicity, several authors did not observe increase in radiation necrosis, hemorrhage, or other toxicity in cases of the combination. I'm out of time. So liver mets, it's effective. The question about it becomes the dose and fractionation, which one is best is a matter of debate, and the timing, sequencing, interval, there is matters of debate. Again, a lot of this is mostly retrospective single institution. Bone mets, the difference with bone mets is that the area that needs to be treated may be larger than just a simple, or like 1 centimeter in the brain. So they've found that the combination of hypofractionated RT and immuno demonstrated significantly higher survival probability due to its immunogenic effect. So conclusions, immunotherapy can synergize with radiation-induced immune activation. It converts the immunosuppressive microenvironment of a tumor into an in situ vaccine, boosting the abscopal effect. Clinical observation of tumor responses outside the irradiated field, and these results highlight the importance of continued clinical investigations to assess the response of radiotherapy combined with immuno, and also pave the way for non-ablative radiotherapy doses in combination with immunotherapy. It can synergize with radiation-induced immune activation. The combination seems to be a safe therapeutic option, supported by clear biological rationale, even though the available data confirm that radiotherapy is employed more for metastatic than non-metastatic disease. And the combination shows promising results in terms of survival outcomes. And these results highlight the importance of continued clinical investigations to assess the response of radiotherapy combined with immuno, and also pave the way for non-ablative radiotherapy doses in combination with immunotherapy. And further studies, hopefully prospective, are needed to confirm this evidence. And the optimal timing and toxicity profile of radiation is kind of still up for debate, depends on location, it's in the brain, liver met, and several retrospective studies have have shown a different median overall survival benefit for patients who receive immunotherapy after radiation or in combination compared to patients receiving immunotherapy before or after 5 weeks of radiation. And SRS compared to EBRT, external beam, was also so basically studies have shown that radiosurgery can be better than just the standard fractionated radiotherapy for overall survival predictor, and the side effect profile in patients receiving radiotherapy combined with did not appear to be different from that of patients receiving either one alone. Now, in terms of what else to think, is melanoma one disease? No. The pathologists have always been arguing that, and we're seeing that they are right again. And I say that because what may work in one subtype of melanoma may not be the same in others. And we better get our act together. This is the predicting model that in the United States by 2040, it's going to double. There's going to be 219,000 invasive cases of melanoma. So they're predicting that in our lifetimes, melanoma will become the second most common major cancer type in the United States, and the most common in males. So we better figure this out, folks. And as you can also see, the timeline of regulatory approvals in the United States for treatment of metastatic melanoma, all these new things that are coming out, we need to figure out also how they work with radiation and the timing. So there's a lot of work that needs to be done. And so Moffitt led an international multi-center trial that will hopefully add TEAL to this list. That's tumor infiltrating lymphocytes. Future directions are prospective trials that are warranted to establish the role of the combination of radiotherapy and immunotherapy for locally advanced melanoma. And these trials will provide further data on the safety and efficacy of immunoradiation for locally advanced melanoma patients. We'd like to acknowledge the help and also for slides from Dr. Kamran Ahmed, Nikhil Kushalani, and Evan Withrick. Thank you. Yes.
Thank you very much for the very nice overview and very useful overview of the new data on the combination of immunotherapy and radiotherapy. My question is about the radionecrosis. So before, 6 months before, I was very sure that there is no increased toxicity with anti-PD-1 in combination with radiosurgery, and we sent our patients for gamma knife surgery or X knife for solitary metastasis in the distant metastasis. But then our radiotherapist from the Gamma Knife Center told me that there are some new recommendations that because of this increased radionecrosis, we should wait 7 days before and after immunotherapy cycle to before and after gamma knife surgery. How do you do it in your center, and have you observed this significant rate of radionecrosis? Because I don't have this experience. Maybe one of many patients have some side effects of radiosurgery, but in my view, it's really a safe procedure. Maybe with ipilimumab it is more toxic, but what is your experience? And do you wait for 7 days before and after gamma knife surgery, or with therapy?
It's one of those that I knew I was going to get asked that, and I should have put the slide in methods for this one, for this paper that just got published. They're not in the paper. You're not going to see that specific how many days before or after. They were just saying that radiosurgery was given within 2 weeks of administration. So it's worth looking into and asking the question about, does it really, I mean, they said these are observational studies. You got to keep in mind, I saw a patient, and sometimes patients teach us, and I'm never going to do that again that way. But it could have been something else. So in not doing an actual clinical trial, or at least based on a trial, I would say be be cautious about interpreting, like not giving in necessarily, like if you do it within a day or two. What we do at Moffitt is we have to make sure that the MRI is right, that the MRI is within, we do it within 3 days.
Okay.
MRI and radiosurgery is within 3 days. You don't want to wait more than a week. And in terms of the timing of the immunotherapy, I would have to ask some of my colleagues how specifically in terms of, does it really matter? Do they see more radionecrosis if it's within 7 days or more? I haven't heard that.
Yeah.
So but I can always let you know.
Okay. One more question is the role of whole brain irradiation nowadays. When do you use VBRT in your everyday practice? For which patients?
Right here.
Yeah.
So
but there are some experts, they say that it's not, there's no use for do you use it just it's just the palliative treatment, and that there is no added benefit with whole brain irradiation versus nothing, just symptomatic treatment?
Well, the partial study is old by now, and I would say it's still valid, that it shows that there is an overall survival. Listen, it's like, again, what is your parameter? There's an overall survival advantage. This is like the one time that I tell patients that my palliative treatment extends survival, not gets rid of your pain. It actually extends survival over steroids alone. So is it about 3-6 more months? Yes. But at the same time, who's to say that you're going to have that exceptional responder? Yeah. So whole brain radiation has been proven to extend survival over, what's the alternative? Steroids. So that is, to me, that has been established. Now, the discussion is more into where do you draw the line, because can you do radiosurgery trying to delay the need for whole brain? And when I started my practice, Wally Curran would make me give whole brain radiation for people who have one resected brain met, because that was the standard of care then. Whole brain, one lesion post-op.
Yeah, but in the European guidelines, and in European centers, it's in most centers, big centers for melanoma, it's omitted because they think that it's not increasing overall survival and it's decreasing quality of life. But for some patients, symptomatic patients, of course, we still use it, but we are just not sure whether it adds something or not.
The point I was saying is, this is when I started my career 15 years ago. We've gone a long way that, we don't offer whole brain radiation unless we absolutely need to. We use radiosurgery, and which is safe, effective, and quick. And if we're going to do whole brain radiation, we also try to do, in as much as possible, hippocampal sparing to improve quality of life.
Okay, thank you.
We have one question from the online question.
Sure.
From Rebecca. This is about radiotherapy and immunotherapy combination in lung metastasis from melanoma. Is this possible or not, or any data? Probably she means some stereotactic body radiotherapy for lung metastasis from melanoma.
So, dang it, I don't know what happened. I used to have a slide about a case. It was about a abscopal effect case, and it had to do with that. And basically, it has been shown again how or why, and why is it not that reproducible, in which they treated a lesion in it was actually part of paravertebral lesion, and then they saw that lung lesions that were previously resistant shrink. So those studies have been, there have been reports about an abscopal effect for lung mets, which is provocative, interesting, and I think I'm missing the expression. What we want to achieve is to be able to reproduce this every time.
Okay. Any questions? Thank you. Okay, you have Virginia, yes, please.
A completely different topic.
Sure.
This is an immunology question. You mentioned that the radiotherapy results in DAMP expression and an increase in CD4 T cells to the tissue. Are any of these T cells Th17, which would be responding to these DAMP molecules?
So the specific subtype of T cell, you got me there. I do not know. It's something that I'll have to obviously look into it and see if that is a specific, because you're asking a very specific biological immunotherapy question, immunological question. Like, what is the subtype of the subtype? But I would venture to say that it would have to depend on many factors, like the site of the metastatic disease, the tumor burden, the dose of radiation that was given. So there's going to be some factors associated with that to see which is the subtype that is being preferentially that comes out.
Sure. Thank you very much.
You're welcome. So, thank you, Roberto.
Yes, a question.
Question, one? Question?
No question, a comment.
A comment, okay. Question, okay.
I think he knows the answer, sorry.
No.
Okay.
Okay. Thank you very much.
Thank you.
Our next speaker will be Professor Alexander Dimovsky. He's professor at Macedonian Academy of Sciences and the leader of and he will speak about predictive biomarkers. You speak generally about overall predictive biomarkers and personalized medicine. So you have audio.
Is this on? Yeah. Hello. Thank you very much for inviting me. It's a pleasure being here. I have been associated with COS for a long time. Been in the management and technical committees for almost 15 years in the early 2000. So, and every time that I'm invited to a COS meeting is a big pleasure to be, especially with friends that I'm collaborating on a daily basis and in the field that it's really my close, not only research but also field of application that I'm doing every day. So the time is rather short, it's only 20 minutes, it's a lot of things to cover, and I have tried in this short period of time to give a very fast overview about the biomarkers in general. This is what, so these are my disclosures related to this, and about the methodologies that are used for biomarker analysis, about approved predictive biomarkers for major cancer types, and also I will open the discussion about the challenges for the implementation for this in routine clinical practice now and some future considerations. Okay, they say when there's an elephant in the room, definition. You always think that you know what is a biomarker, but it's always good to remember. A defined characteristic that is measured as an indicator of normal biological process, pathogenic process, or responses to an exposure intervention. So it encompasses therapeutic interventions and can be derived from molecular, histologic, radiographic, or physiological characteristics, and they're different from direct measurements of how persons feel, function, or survives as a category of measure known as a clinical outcome assessment. This is related mainly to clinical trials. So when we speak about biomarker, it's just good to know or to be reminded about this a long process before we get one biomarker to the clinic. So it takes sometimes years or tens of years and it goes in these 5 major steps, starting from discovery, initial discovery and validation. There are a lot of research, basic research, either genomics, proteomics, metabolomics, or high throughput screens now, data mining, and so on. And then there are large cohorts of patients are screened to ensure statistical robustness and reliability of the data before it is then progress to the second stage of clinical assay development, which should be reliable, accurate, in measuring the biomarker in clinical samples. We are always concerned about sensitivity and specificity of biomarkers. And this optimization are very important. Then it goes to this pain in the neck part, which is the regulatory approval, the regulatory part of the submission to the extensive data demonstrating the analytical and clinical validity, and finally goes to this clinical validation stage, where there are validation studies in real-world clinical settings to confirm the clinical utility of the biomarker. So it's a long, finally, at this stage, they are done, which is extremely important, the cost-effectiveness studies and the feasibility of implementing the test in clinical practice. And finally, there is clinical implementation, in which there is training of healthcare providers, updated clinical guidelines, and continuous monitoring, evaluation of the test performance and impact of patient outcomes. So it's a long and complicated process. But there is a great interest in developing new markers. This is a slide in which we made a search in Skopje about documents, biomarker, and then which appears in the title, in the abstract, in the keywords, and then whether it is a biomarker in the discovery phase or in the implementation phase. You can see in the last 23 years, this from 2000 until the last year, there is a steep rise in the number of biomarkers that have come to the clinic or to the attention of the clinic, mainly in the discovery phase, but there are quite a few, almost 1,000 publications for the implementation of biomarkers in the clinic. So also one very important thing when we are speaking about biomarkers is the methodology. Specimen, one thing is specimen type, where you can analyze them in which media, and the other thing is methodology by which they are being evaluated. In terms of specimen type, they can be analyzed in any type of matrix, like in blood, in tissue, in other types of bodily fluids like urine, CSF, saliva, etc. Or it can be done analyzed in cell culture. Concerning the methods, well, generally we say that there are some definition of biomarkers where they are molecular, and then we speak about markers which analyze the DNA changes or RNA changes or protein biomarkers, in which they are analyzed by either immunohistochemistry or ELISA or some spectrophotometric techniques. Or there are cellular methods in which they are analyzed by flow cytometry, and etc. There are differences for various biomarkers, but what we are seeing now, when I haven't prepared a slide for that, it's important that we have assays in which we evaluate one single biomarker, or we have assays in which we evaluate a complement of biomarkers, or we have assays in which we evaluate all biomarkers. So what is coming now to the clinic, actually, is this so-called comprehensive genome profiling, in which in one reaction we can analyze all known genetic or molecular biomarkers, both on RNA and DNA levels, analyzing more than 500 genes at a time. So when we are speaking about biomarkers, there are 7 different types. And I will just go fast through them. First is the susceptibility risk biomarker. They are used for, they indicate the potential for developing a disease or medical condition. Individual who does not currently have a disease, for instance, BRCA1 testing, Lynch syndrome mutations, okay, I will just show some pictures of our data. This is NGS detection of one mutation in MLH1 gene and confirmation by Sanger. The second type of biomarker is a diagnostic biomarker that detects, confirms the presence of the disease or a condition, for instance, PSA screening or mutations in genes associated with MPN. Here's detection of the JAK2 mutation in patients with myeloproliferative neoplasm. The third is monitoring biomarker. A marker can be measured serially to assess the status of a disease or a medical conditions for evidence of exposure to a medicinal product. And this is now, for instance, one more fancy assay. This is the detection of EGFR mutation deletion in by liquid biopsy in plasma of patient with lung cancer. So this is a diagnosis at 10%. Then after therapy, 1 year therapy with the first generation of EGFR, there is a complete remission. And then after 2 years, there is a relapse of disease detection of 1% of mutation in blood. Then we have the pharmacodynamic or response biomarkers. These are biomarkers that change in response to therapy. For instance, the changes in BCR-ABL transcript during therapy in patients with chronic myelogenous leukemia, the changes in BCR level, then after treatment, complete remission, and relapse after 1 year development of resistance. Safety biomarkers are now also coming to the market. These are markers which indicate the likelihood, the presence or extent of toxicity as an adverse effect of exposure to a medicinal product. These are mainly pharmacogenetic markers. We do a lot of this. Here is the example of detection of variants associated with toxicity with fluoropyrimidines, which we test before starting. Is now a routine test for our patients here in Skopje. And now we are coming to the last two. One are the prognostic biomarkers, which are, there's the most of the interest are in these. These are prognostic markers which are used to identify the likelihood of a clinical event, disease recurrence or disease progression in patients with a disease or a medical condition. I'm showing one detection of deletion of the short arm of 17th chromosome, where is 53 gene, in patients with CLL, a very important prognostic biomarker. And finally, we are coming to the predictive biomarkers, which is the major topic of today's talk, which we defined as the presence or a change in the biomarker which predicts the individual or a group of individuals more likely to experience a favorable or unfavorable effect from the exposure to medicinal products or environmental agents. Actually, or say it in a few words, these are markers that are just giving us information whether a patient would respond to a certain therapy. Especially they are linked to the therapeutics, to the targeted therapeutics. And that's one example for predictive biomarker is detection of a BRAF mutation in patients with melanoma, because melanoma is the subject of this workshop. V608, this is our validated in-house assay. But there is some mixture between prognosis and prediction, both in the interpretation of what is prognostic, what is predictive, and there are a lot of markers that are both prognostic and predictive. And for instance, microsatellite instability is a very good example for that. And here's an example of one method that we use for detection of microsatellite instability and normal, and you see, you can acknowledge these extra peaks on the chromatograms at the bottom, which indicate the presence of this trait in a sample. Now, how many predictive biomarkers do we have now in the armamentarium for use? Now we search the NCCN compendium of biomarkers, and we analyze them for each specific disease. And they are listed here in the number of biomarkers for the major malignancies. So you see, the most are, we have for biliary tract cancer, there are 18. Then we have a lot for breast cancer, 16, head and neck, 14, and then there are a lot of them, most of them are for patients with digestive tract cancers. For non-small cell lung cancer, there are 12, and then the number fall down, you will see there are fewer and fewer markers for other conditions, and what's surprising, there are very few, almost not existing for leukemias. Only 2 for childhood leukemias and lymphoblastic leukemias, for the time being. And also, when you see there is a list of malignancies which lack a predictive biomarker. For instance, there are some very common cancers like prostate cancer, small cell lung cancer, pancreatic adenocarcinoma. There are no predictive markers. That are on the list of NCCN. These are biomarkers with the level of evidence 1 and 2A. Now, if you see the data from the other side, how many indications can one biomarker have? There are not so many. You see, you saw there are maybe 20, 30 conditions, some of them 20, 15, 10 different biomarkers. One can imagine that there might be 400, 500 biomarkers. There's just a relatively limited number. There are 46 biomarkers that are on the list that can be tested. But when you see how are they distributed over different conditions, there are great differences. For instance, there are some of them that are very common. For instance, microsatellite instability, or this MMR phenotype detection of the absence of these 4 genes is indicated in 20 different conditions, NTRK in 18, RET in 13, BRAF and HER2-neo-RBB2 in 11, and so on. And there are some, for instance, these at the bottom are really in only particularly in rare conditions. And from this, there came a notion that some of them can be really treated as something as agnostic biomarker, which means that they can be used for any malignancy, no matter what histology it is. As you just test for every patient. And when you have it, you can just use the therapy no matter what is the histology. But a note of caution for that, because very early we have learned from this, from the experiences about BRAF mutation. Firstly, it has been used for treatment of patients with melanoma, but it has been tried for other cancers, especially in colorectal, I know, because this is my closer field of interest. There was a big disappointment. So response from 60–70% in melanoma fell to almost non-existent in colon cancer. And there is a biological explanation for that, but we should be aware about these differences when thinking about this agnostic use of biomarkers in oncology. And other things that I think that are important, when you see that some biomarker is, for instance, positive, can be used for certain anatomic localization or for certain, let's say, here I gave an example of a genitourinary tract. You can see that one type of biomarkers can be used for bladder cancer, and there is a completely different set for upper GI tract. And for instance, for other histology like urothelial carcinoma, there are no biomarkers. And also when you are speaking about specific changes, then you have to be aware that either they are testing the changes in the same gene, there are different assays for different indications. For instance, for EGFR, you test this 19 deletion in the 19 exon, or this mutation as an indication for first-line TKIs, EGFR TKIs. But you have another mutation that you test as an indication for resistance to this therapy, for indication for the second-line therapy for TKIs. And for instance, also in leukemias, for BCR-ABL transcript, we just detected this indication for the first-line generation, but mutation in the ABL gene further to progression indication for switching to second, third, or even fourth line, depending on the type of the mutation. So there is some complexity in these tests. Now I have listed in few slides the biomarkers for the major cancer types. For instance, for breast cancer, there are 12 different tests. You see with gene, I listed the genes. I don't have, unfortunately, time to go through this. The molecular abnormality that is being evaluated, whether it's expression of the gene, or whether it's a mutation, or the rearrangement, the methodology used, the category, and as you can see, the recommendation is actually, for the time being, mainly for patients with metastatic disease. This is mainly for patients. We should be aware of this, unfortunately. For metastatic, very rarely they are used for patients with indications for adjuvant therapy or for locally advanced disease. There are some of them that are coming now to the market for that, but there are just a few. And in the last column, there is a specific therapy which is associated with each marker. I haven't listed the specific drugs, but the group of drugs that are associated with that marker. These are for non-small cell lung cancers. There are 10 different tests, so this adds to the complexity and to the approach of treatment. Previously, when we were treating using biomarkers for lung cancer, we were testing initially only EGFR, and then came ALK, and now we have these all 10, because there are drugs for all of this. And they are very efficacious. But the testing, the methodology for testing, the price and the complexity of interpretation is becoming more and more difficult. Come to that at the end. This is the one for colon cancer. Initially there were just a few, it was only MSI, then came KRAS with the cetuximab, and now we have this BRAF and HER2, NTRK, RET, and so on. And finally for melanoma, we have 5 biomarkers. Initially it was BRAF, they came KIT, NRAS for ICIs, NTRK, and ROS. About predictive testing, testing for predictive markers in Macedonia, I've made a mistake in the title, sorry. We are lucky that we had a good start in this field some 25, 30 years ago with the development of the Center for Genetic Engineering at the Academy of Sciences, which was really a hub that trained a good group of people some 25 years ago, which are now a network of people that are able to really introduce this field relatively easy and fast into clinical practice. And we are communicating with ourselves, we are coordinating our activities. And currently, what is the situation? There are 2 major laboratories, one at the Department of Pathology at the Faculty of Medicine, the other one at the Faculty of Pharmacy. They are doing somatic testing for biomarkers. At the Academy Laboratory, which is the major laboratory in the country, and at the Institute of Immunology and Genetics at the Faculty of Medicine, they are doing this germline testing. At the hematology and pediatrics, they have their specific tests, and also their testing facilities at the 2 large private hospitals here in Skopje. What are the current challenges? Like everywhere, high cost. These tests are rather expensive, and as I said, when we are moving to this multi-parameter testing, they are becoming even more and more expensive, which is really prohibitive if you want to implement them on the nationwide basis for all patients. The other thing which really concerns me, especially in countries of our region, I know whether it's everywhere, but in Macedonia certainly, that you can do testing, but we don't have all available therapy for which we can do that test, and this is a big problem for implementation. And the third thing is the technical experience in the interpretation of data, and these tests are not a regular blood group. Determine the blood group or CRP can be very complex sometimes. I'll just give you a few examples. This is the detection of a test by Sanger for detection of the KRAS mutation. By the same patient insists we find another mutation. So if you have this and you test this sample by a different method, you will detect it as a negative. So you have to know the limitations for each method when you are testing what you can expect. So the second thing is these are our data that has been corroborated in a major paper a few weeks ago. In which now MSI is very important marker because it is one of the major prognostic factor for the immune checkpoint inhibitors therapy, which are becoming really a mainstream of therapy in oncology in the last years. And MSI testing, when you do it very carefully, we did it on a group of patients for which we know the defects that are causing the MSI. So mutations in the genes, in the MMR genes, which type of mutations we have, or in the sporadic cases, what is the promoter methylation status. And then we were evaluating 3 different methods for detection. Detection by classical immunohistochemistry, molecular MSI, and detection by NGS. And we have big discrepancies. There was a concordance in only 75 to 80% of samples, and there were samples which were detected only by NGS, but not by MSI or not by immunohistochemistry. I don't have time to go into this, but this is related to the place of the mutation, type of the mutation, etc., etc., the level of MSI, which indicates that we should really, if you think about these differences that we see at the level of MSI, might actually be translated to the efficacy of immune checkpoint inhibitors in therapy in this group of patients that has been observed. No data available at the moment. Hopefully we'll have them soon. And the bioinformatic analysis of this data, extremely variable in different places. One example, if you evaluate one data only in the tumor, not compared to normal, or comparing to the different or wrong data set, normal data set, you might get a wrong result for important parameter like tumor mutation burden. Because normal variations that are in populations, the software will count them as a mutation in the tumor. So this has happened, this has been published just several months ago. And finally, this really points to the necessity for introduction of molecular tumor boards when thinking about implementation of this type of testing. I think that this has been now a mainstream of recommendations in many, many academic centers. Hopefully, we have initiated now a preparation of a strategy for implement at the academy together with everybody here from the clinic, so to implementation of the strategy for this type of precision oncology in Macedonia, which I hope we will envisage introduction of these boards in the future. And what is also important, to have a comprehensive platform for evaluating of the implementation of this type of precision medicine in the clinic. Future prospects, agnostic biomarkers are very, very interesting, but we need a lot of more data, but I'm positive that they will come through. We are needing additional high throughput data that are coming for proteomics, epigenetics, from imaging, etc., into one platform. Continuous monitoring through liquid biopsy, that is, I think, something that will becoming very strong in the years to come. And finally, the use of artificial intelligence into sorting out what's what and their place in the everyday practice. This is a field on its own. We don't have time to get into this. I will stop here and be happy to take your questions. Thank you very much.
Maybe just a comment. Do we have a place for artificial intelligence in now algorithms or something which can let's say predict, maybe using the biomarkers to
the same group of patients? I think it's too early. There's always place for it. It's only whether you should just ask it what to do with it. But
we are not able to apply straightforward. I mean, absolutely.
We have too much intelligence on our own. We don't need it.
Hope.
Just about your taking into consideration your experience in this field of work, I would just ask something that bothers me sometimes. When we are speaking about precision medicine and personalized medicine, and having in mind the budget restrictions that we have. For example, if we decide that we should put a lot of money in one patient and apply everything we have, we will get to a certain level of personalization treatment for this patient. But just in your experience, how do we select what would be the adequate level, what to apply, and equally divide
Thank you very much for your question. I don't have any idea. But in general, these are decisions that should be done by studies that include this health technology assessment and pharmacoeconomics. So each country is setting up the height of the bar that they can really afford to implement in the country. If they say we don't have money for this, we don't have money for this period, we don't use it. But we have to work with data, not we just don't have money. Let's show them the data, show the costs, show what is your level of approval, and then we can talk with the officials whether they should find some extra money, definitely. Without extra money, it's impossible to implement this.
Thank you very much. Thank you, Professor.
Thank you.
Professor Dimaski. And the next speaker is Professor Virginia Calder from University Clinic of London. She came from UK, especially for this event. It's yours. No, another one.
Here.
Another one.
Okay, lovely, thank you.
Probably this is. You're welcome.
I'd like to thank the organisers for inviting me today, and I have to declare that I do not work on melanoma, so you can go to sleep now. I am an immunologist working in the eye, in inflammatory eye diseases. But it is fascinating to come here today and hear all of the issues that you have and are facing, because they're very similar in other diseases. For example, at the back of the eye, it's an immune privileged site. The local immune cells are very immunosuppressed. We have the same issues. How do we manage that? How do we overcome that? So I'm hoping that you'll be able to take something away from this talk today. The aim today is really to talk about the very different immune pathways that are involved in the different ocular inflammatory diseases, and the fact that each patient within a clinical subtype of disease, these patients can respond differently. And so in terms of being able to predict responders for immunotherapy, we need to look at the patient specific basis to work out, are they good contenders for this immunotherapy? So I'm going to very quickly talk about allergic eye diseases, starting with this spectrum of disease here. On the far left, we have seasonal allergic conjunctivitis, and many of you in this room may be sufferers. It comes and goes, and it's very much a mast cell driven problem. Fortunately, the cornea is never involved and affected, and so you're not at danger of losing sight or having any visual impairment. The ones on the right that I've circled, atopic keratoconjunctivitis and vernal keratoconjunctivitis, are very rare, but much more severe, where the cornea can become infected and sight can be threatened. So I'll talk about those in a minute and just quickly go through the allergic diseases, the seasonal and the perennial. Perennial is simply that the allergen is usually house dust mite or cat, and you can't really escape it. So because the allergen persists, the cells in the tissues are a little bit more varied. So it's not just mast cells in perennial. It tends to also involve T cells and neutrophils. So the treatment's a little bit more complex. You may have to go on a short dose of eye drops, steroid eye drops, dexamethasone. They work very effectively, but you do not want to have to take those long term, and you particularly don't want to take them if you're young. You can raise your risk of infections if you do so. So an ophthalmologist's goal is to take these steroids topically for short, sharp doses and just to kind of arrest the immune system. But mast cells are clearly very important in both of these types of conjunctivitis. And mast cells, you may remember, going back to your medical training, they're at the center of innate and adaptive immune responses. They can produce lots of different cytokines, which can promote B cells to make antibodies. They secrete a lot of chemokines to attract in eosinophils, neutrophils, etc. And really, for serious allergic diseases like asthma and dermatitis, mast cells are playing a very important role here. Many years ago, we set up a human mast cell model because it was very difficult to get enough mast cells from tiny conjunctival biopsies to look at those. And so these are actually expanded from stem cells, and we end up with about 20 million cells after protracted periods of culture. They're very pure, and they express a lot of tryptase, a little bit of chymase, and some c-KIT as well. So they are quite good models for human mast cell function. And we use them to look at the effects of these third-generation anti-allergic eye drops that are available for treating seasonal and perennial patients. And much to our surprise, we found that each of these anti-allergics had a slightly different inhibitory effect in terms of the cytokines and the chemokines that the mast cells were able to secrete. They were all very good at stabilizing the mast cells, so you can see the histamine levels were all significantly reduced. Most of them reduced IL-5, but then after that it was very variable. And in real life, if you are a serious sufferer, you'll know that not all of these anti-allergic drops work. And you may take one type of drop in the morning and then another type later on to try and target a wider range of cytokines. And this is really what we saw in vitro. So the key take-home message here is that each treatment has a slightly different effect in terms of the resulting cytokine pathways that you see. And so I think, if anything, don't make it too focused on one treatment. Try and keep your treatment slightly broader in order to have a better effect. Now, moving on to the more severe forms of conjunctivitis, this is where we have much more T-cell driven, CD4 T-cell driven disease. So the upper picture here is showing you, hopefully, some giant papillae. If you can see my, no you can't, giant papillae, these lumps if you evert the upper eyelid. And we're able to biopsy these. In fact, in some patients, these papillae grow so large that it's impossible to close the eye, and that causes dryness and a risk of secondary infection. So in many cases, these are resected. So VKC has a strong association with atopy. There's a seasonal worsening of the disease, but in fact, the inflammation is active all year round. And you can have visual loss because the cornea can become affected. The picture at the bottom is a patient suffering from atopic keratoconjunctivitis, or AKC. This is the adult version. And it's only diagnosed if the patient already has either asthma or atopic dermatitis. And as you can see, you often see these corneal scars. There's a lot of secondary infection, dryness, tear dysfunction. So this is really quite a serious problem. Fortunately, it's relatively rare, but it's closely associated with atopic dermatitis. And in fact, tacrolimus ointment, which is often used in dermatitis, if you put that on the eyelids going to bed at night, it manages to have a beneficial effect in the conjunctiva overnight, so that helps. These small inserts here just reflect the key finding here is that you need to look in the tissues to understand what immune pathways are going on. And as you can, well, you may or may not be able to see from here, but there are Th2 cells mainly, these allergic cells in VKC. But in the bottom picture in AKC, you also have the presence of Th1 and Th17 cells. And we found this out as a result of quite extensive immunohistochemistry, where we were specifically looking for these T cell subsets. I came in many years ago now, but we grew T cells from these tiny conjunctival biopsies, and we looked for their cytokine production profiles. Now, the graphs on the left here, the open bars are paired blood samples from the same patient. So, of course, we saw plenty of Th2 cytokines, IL-13, IL-5 coming up. These patients have either asthma or dermatitis, so they're already very atopic. The patients with the VKC also often have Th2 cytokines, but we could also see in the conjunctival cell lines the presence of these cytokines. What was extremely interesting was that in the AKC patients, we also saw the increase in interferon gamma, which is a marker of Th1 cells. And what we realized from this was that, as we'd seen in the tissue sections, this is not an allergic disease. This is an autoimmune-like disease. It's immune-mediated and it's causing damage. The graph at the bottom here, I should say, is a control group. These are contact lens wearers who develop giant papillae. They also have plenty of CD4 T cells in there, but the levels, if you can see from the scale, the levels are very low, and they form a good control for conjunctival responses. When you look at tissue sections, you can also see significant expression of other Th2 cytokines like interleukin-13. And the question is it driving the disease itself, or is it just part of a mucosal response? We're talking about the conjunctival surface, lots of mucosal associated cytokines there. More recently, we found also the presence of Th17 cells. And I would like to propose that Th17 cells, which are stimulated by the expression of DAMPs, are just as pathogenic in the conjunctiva as in very many other autoimmune diseases. They are very adaptive, they are flexible, they can re-differentiate into Th2, Th1, so it's very important to understand exactly what their role is at the ocular surface. And this flow cytometry graph at the top here, figure E, is actually double stained CD4 T cells stained with markers for Th17 and markers for Th2 cells. And what we're seeing in each of these graphs is a very different type of response. Some of them just have Th2s in panel, the first panel here on A. The panel over on the far right, though, have much more Th17 component. Question is, what is there a prognostic value to these tier levels? And we're looking into this at the moment. What we could say from this study was that there was an inverse correlation between high Th2 and the high Th17. So they were either one or the other. And so this is very interesting because it does suggest that whether as a response to treatment or the disease itself, there are different types of T cells that can be driving what looks like the same inflammation at the ocular surface. So, of course, there have been many other reports looking at tear fluids. And this study here was using an antibody array, looking for the presence of different cytokines. And the panel on the left, these are normal tear fluids collected from patients, and really very, very quiet. The main cytokines that you could detect were interleukin-8, which is quite a prevalent cytokine in tears. However, in AKC patients, on the right-hand side, you can see a lot more spots coming up, plenty of IL-4, which would be a typical Th2 cytokine, but also interferon gamma, which validates what we saw with our cell lines and with our sections. You can also look at incidence levels of these cytokines. This is a study where we've just recently been comparing two different forms of conjunctivitis, both affecting kids. And interestingly, some quite stark differences in that IL-23 was markedly upregulated in patients with BKC, but not so in the VKC panel on the right. In VKC, it was a very different profile. With plenty of chemokines, CX3CL1, otherwise known as fractalkine, or CCL20. So again, we can see at the level of the tears very different pathways being activated. And we feel that this is a non-invasive way of getting an indication of what's going on at the ocular surface. It has been used in studies for biomarkers for a number of different eye diseases, pterygium, glaucoma, diabetic retinopathy, where specific changes in VEGF levels, etc., can be detected, and they're hoping to use this as a much cheaper, more accessible readout of what's going on. Interestingly, there have also been a number of studies where they've looked at tear fluids for non-ocular diseases. So this study here looked at pro-inflammatory cytokines during a COVID infection, and they saw the typical upregulation of a variety of different antiviral cytokines. There was also significant increases of IL-8 and interferon gamma in patients with cystic fibrosis. And then a recent study looking at colorectal cancer where they found increased levels of microRNA in tear fluids. So it's a venue worth pursuing, avenue worth pursuing. Okay, so to get back to the immunology, there are T cells everywhere, there are mast cells everywhere. What is going on in different diseases? And we look on the immune system nowadays as very much a balance. They regulate each other, and hopefully in a normal, healthy tissue, there are some of these cells there. They're just keeping each other in check. So if you look at the Th2, the allergy-prone T cells, these actually antagonize the function of Th1 cells, which are autoimmune. They also antagonize the Th17 cells that I mentioned, the DAMP-specific T cells. So if you've got some Th2 cells there, which you will in a mucosal site, you'll be keeping your other more dangerous T cells in check. The question is, what happens when that system becomes out of balance? And of course, in the allergy world, just as in the myeloma world, there have been a whole range of cytokine-directed therapies and immunotherapies developed for allergic disease. Omalizumab, the anti-IgE, is very acceptable treatment. But I just want to talk a little bit about dupilumab, which you may have heard of, where, ideally dupilumab would be a great candidate for treating allergy because of its ability to block the effects of both interleukin-4 and interleukin-13. And it works very, very well and has become an absolute game changer for treating patients with atopic dermatitis. They absolutely love it. However, once you inhibit these Th2 cells, you are, of course, upsetting a balance. And if there are other T cell types there that were previously kept in check, they might not be inhibited. And I was talking to a dermatologist at a meeting before Christmas who was talking about his patients on dupilumab. They absolutely love it, but some of them go on to develop psoriasis. And he has to then transition them away from the dupilumab and onto an IL-17 targeted therapy to cope with the psoriasis. And so you get into this kind of yo-yo situation, again reflecting the fact that you need to be careful. We've come so far in developing these very, very specific treatments, but are we being too specific? And certainly for balancing immune pathways, I would argue that in some cases that is the case. So I'm getting to the end now. I just wanted to reflect on this a little bit. It's important that we have a good balance between our pro and our anti-inflammatory cytokines, certainly in ocular allergy. And whilst we're desperately trying to understand what are the specific pathways that we need to block, we must be careful not to allow other pathways to re-emerge as a result, and that can cause even more severe effects. And you might be asking yourself, well, what on earth does this have to do with melanoma? Okay, well, first of all, another problem with dupilumab is that, in fact, there have been a number of cases of dupilumab-associated ocular surface diseases arising from this treatment. Most of them seem to be treatable. They need to go to ophthalmologists, and most of them are given steroids to dampen down the response. But they need to be treated quite quickly, and so it's quite important that close monitoring of these patients takes place. And there have been a number of studies recently where they're looking at, are there risk factors for those patients who have this ocular surface comorbidity. And it turns out that if they have any history of having an eye problem, they are at a higher risk of developing this ocular surface problem. Interestingly though, we haven't quite worked out why, patients who are being treated with dupilumab, but this time for nasal polyps associated with chronic rhinosinusitis, those patients don't suffer ocular surface adverse events, and we don't quite understand the immunology around that yet. Okay, so a couple of comments about your much more challenging situation. You have a tumor environment which is very anti-inflammatory. And we have a similar situation at the back of the eye. So everything, the cornea itself is immune privileged, very important to keep it away from the immune system. But also all of the back of the eye, which is a huge, huge area, is immune privilege. Now, when I say immune privilege, I do not mean it doesn't have any immunology at all. In fact, it's a very proactive process to maintain an anti-inflammatory environment with lots of soluble factors to suppress immune activation. So I came across this paper when I was reading around the myeloma world, which is a fantastic summary of the ocular toxicity associated with the different anti-cancer agents. And many of them affect the back of the eye. So clearly in those situations, the immune privilege has been compromised. And we end up with quite severe autoimmunity and other diseases associated with these sorts of treatments. Similarly, at the front of the eye, you can see dry eye, you can see anterior uveitis, conjunctivitis, etc. So very important to understand what we're trying to inhibit here and how to treat these. And I was interested in, I talked to a corneal specialist before I came out here, and he was saying how serious some of the corneal effects are in response to some of the treatments. So we do need to be quite careful that these are picked up as early as possible. In fact, some of these papers, this one down at the bottom here, is proposing that for clinical trials with myeloma immunotherapy, we do need to think about involving an ophthalmologist in the planning of the trial, just to make sure that these side effects can be picked up early enough. Okay, so in conclusion, in the immunology world, my biomarkers are changing all the time. They're not lovely gene mutations that stay static throughout. So we have to keep on top of which are the key cells driving the disease at any one time. And that's where I really think tear fluids could be a great way of quickly looking to see what kind of cells are activated during disease. We need to understand the key pathways involved before we go in with these very specific inhibitors. And just because we can target Th2 cells with dupilumab doesn't mean that it solves the problem in all cases, given that there are lots of other cell types present that could be reacting. And I'd just like to thank you for your attention.
From the audience? Okay, Professor Calder, thank you for your inspiring lecture. I would like to hear your comment and opinion about the possibility to draw a parallel between the, let's say, imperfection of the mechanisms for driving the maturation of our immune system, for example, the positive and negative selection in the thymus for T cells, etc., and some odd and counterintuitive events, like, for example, that some immunodeficiencies develop, are prone to, patients with immunodeficiency are prone to developing autoimmune diseases.
Thank
and
you.
When we are speaking about the activation, for example, of T cells, TH1, TH2, their balance, and the interplay of B cells, macrophages, etc. Would it be more important not the number of cells and the presence of receptors, but the activity of the signal transducing pathways and the actual level of stimulation of the nucleus, and not just the presence of, for example, PDL or whatever, or CX, CR4 or CCR5 receptors?
Yeah, no, I mean, absolutely. I would say that for personalized medicine, just before you're about to give them that treatment, check the degree of activation of the different cells there, because that will predict how they're going to respond to these treatments. I was interested in hearing earlier today about the effects of stimulating the immune system with some of these checkpoint inhibitors. Fantastic idea, but we don't want to stimulate them in the back of the eye. So we need to understand that the cells within the tumor are heavily suppressed. They're not going to help us. It's the ones outside that we then want to stimulate to go in. But the ones inside, they are completely inhibited and switched off. So again, what can you see, for example, in the blood, in the tears, in any of these fluids? What's happening at the time that you're giving the treatment to get an idea of how the patient will respond? Definitely very important.
So we should better check what stimulation causes the PD1, PDL1 interaction rather than just confirm their presence.
Possibly, or at least if you look for PDL1, where is it expressed? Which cells are expressing it? Are they already activated or not? And that way get a handle on the direction in which the treatment is likely to work. Yep.
Thank you very much.
Used when you present about immune system for students, for doctors, because immune reaction is very complex, and we need to know that two arms in immune system, or generally, innately contain many cell subtypes, including natural killer cells, many proteins. We have two arms in specific cancer and immune system. Cells are very important. B lymphocyte express very minimal role, contrary T cytotoxic lymphocyte. NK cells have important role in cancer because tumor is modulated by antigen, and not all tumor express major histocompatibility complex. This theory, Barnett indicated that tumor escape immune system, so NK cell working absolutely different in comparison to T cytotoxic lymphocyte, and upregulate several ligands, and there is good candidate to kill cells, of course tumor cells. So many signals that exist in the peripheral blood, including cytokine, regulate NK cell. Also, NK cells have a very, very important role in tumor-stroma interaction. Also, NK cells report very good results depending on hypoxia, VGF, neoangiogenesis. So, NK cells are very important cell type to analyze in the cancer. First data about NK cell originate about 50 years ago. At that time, NK cells called only large granular lymphocyte, and first evidence indicated that there are cells looking for leukocyte but exhibit function similar to T cytotoxic lymphocyte. Until this data, until today, we have evidence that NK cells express anti-tumor activity, specifically regulate reproduction, have role in immunomodulation, regulation of phases, and many other functions in the body. Today, NK cells are classified a specific type of innate immune cell type 3 based on morphology and cytokine production. NK cells originate from bone marrow after several steps of differentiation circulated in a peripheral blood, adhesive molecular function, and exhibit many functions. How NK cell working after activation receptor stimulation? NK cell express effect or kills tumor cell using two model: secretory or non-secretory model. Non-secretory based on TNF superfamily, and secretory are based on production of cytokine, firstly perforin, TNF, and interferon. We have different subset of NK cell, mostly divided in two groups: CD55 bright and dim, based on surface molecule expression and also about amount of intracellular cytokine, including perforin. Balance of NK cell is regulated between activity of activating and inhibitory receptors that working simultaneously, and also in context to intracellular amount. We have high or low expression cells divided as CD45 bright and CD45 dim. How we measured NK cell? There is two options. First, we have option to measure number of cells and determine an activating molecule, and contrary to this, we have option to look NK cell function with different assay. This is typical flow cytometry data indicated NK cell subset different in comparison to T NK cell based on CD3 negative. When we look in immune system in periphery in healthy people, for example melanoma, we compare different cell subtype, and if you want to look monitor immunosuppressive effect, we achieve this only by NK cell. If you look this graphic, we see the healthy control in melanoma have significant discrepancy in NK cell activity. Other subset or subset, peripheral B cell, T cell, monocyte, is absolutely similar. So NK cells are very specific for immune system. Other option is examining NK cell receptors. We're looking for CD356 in combination, bright and dim, and we have also difference depending on clinical stage. We're looking also activation receptors, and we find that in melanoma patients, activating receptors in contrary to other is also because NK cells circulated in a bone marrow, spleen, lymph node, peripheral tissue, and against tumor. It is very interesting to analyze lymph node and looking NK cell in lymph node. We have data that patients with melanoma and involved lymph node and without lymph node have different CD3 NK cell. This is data indicated similarity between TIL, tumor infiltrating cells. This data that NK cell penetrated start to kill tumor. This next slide we see if you really activated. So we're looking for lymph node involvement, and we see good correlation between this data. Also, if you look activating an receptor, we have evidence that lymph node after infiltration showing activation in activating receptor increase, but we have also increase and inhibitory receptors. So balance is absolutely cell are stimulate and cell inhibit. But if you look who is make this activation, we have data that many cytokines produced in tumor stroma induce inhibition, possibility to induce activation or inhibition. Several cytokines like IL-2, IL-12, 15 are good candidates for receptor stimulator. But contrary to this, we have predominance of negative receptors like to TNF, TGF, and IL-10. All of that cytokine produced for tumor induce inhibitory receptors. So general conditions, NK cell penetrated, NK cell induced activation, but effect is minimal and effective suppressed. and we have failed effect of NK cell activity contra tumor. This is very complex evidence, and this is absolutely new evidence indicated that immune system in cancer is under general suppression. Second possibility is to analyze NK cell function. We have many assays and used previously. We firstly labeled target cell with radioactive chromium, mix NK cell from donor, healthy people or patients. After 4 hours, we're looking by gamma scintigraphy, we're looking amount of released chromium, and we measured NK cell activity. NK cell activity also indicated suppression effect in clinics, depending on clinical stage, depending on many other factors, like through inflammatory, like to other enzyme. For example, in melanoma, LDH is very good marker. So we have that patients with high level of LDH have suppression of NK cell activity. We also look NK cell activity depending on survival, and we have good data indicated that clinical stage depending decrease NK cell activity in different cancer, including myeloma, show different survival depending on NK cell activity. Correlation also exists between NK cell activity measured by function of NK cell and correlate very nicely with a receptor activation. Second assay that we use to analyze NK cell activity and escape radiation in the clinical practice for every day is enzyme based on intracellular amount of LDH. We replace this assay because it's non-toxic, non-radioactive, and we use this assay in everyday practice after several correlation, and we also obtain data that during disease progression, in this case Hodgkin or non-Hodgkin lymphoma, with depending on low, intermediate, and high grade or clinical stage, we have changes, statistical changes in NK cell activity, also indicated that NK cell activity are suppressed in advanced clinical stage of disease. NK cell activity also showing intracellular amount alteration, because during decreased activity, amount of intracellular enzyme on cytokine is released. This indicated that NK cell possess cell membrane damage, that all intracellular amount is released, and that NK cell cannot kill tumor. This is major points in this study performed many years ago. When we look activation NK cell receptor and many other parameter like the function, we showing that all parameters correlate. When we look specific case and when compare CD4, CD8, when compare with NK cell, compare with IL-2 production, we can see that good marker and better than other is NK cell activity receptor expression, no changes in CD4, CD8 in the range of reference, and also very low function on that cell type, indicating that cells are suppressed. Next possibility is analyze intracellular marker or intracellular molecule in NK cell. When we look capacity of NK cell to kill tumor, we also finding that melanoma, contrary to healthy person, showing very low NK cell function. To obtain pure cell population, we today have a specific option and using immunomagnetic separation for peripheral blood, and we try now to separate a cell from peripheral blood cell, isolate cells and looking for gene inside, and also looking for intracellular amount. We have not collect data in this moment about that because it's very expensive protocol. Many years ago, when we look different therapeutic protocol for melanoma, we analyze NK cell activity in peripheral blood cells, and we apply different therapy like to interferon as immunotherapy, and we see that only during first cycle NK cell activity is increased, but next during progression or resistance NK cells slightly decrease, and only after several combination little is increased NK cell activity, but generally correlate with pure response to immunotherapy. So this data indicated that NK cell can be good marker for immunomonitoring. We also look this marker when apply interferon, retinoic acid as traditional protocol many years ago, and we look activating a receptor like to CD9 on cell surface, and we see the cyclic dynamic during time in the beginning, before therapy, we have activation, but NK cell cannot stimulate it so much, and we can decrease after several cycles. When we compare capacity of NK cell to produce effective cytokine, we show data that healthy controls always produce much more release of intracellular amount than people with cancer, in this particular case melanoma. So this data also indicated that capacity of cells, especially NK cell, to produce effector cytokine is limited. So if you use any stimulatory effect, we cannot increase capacity because generally cells are empty, no intracellular amount of cytokine, or not possibility to more stimulate. So to escape this traditional principle immunostimulation, today we have new data and new idea to apply new therapy based on checkpoint inhibitor on NK cell, and also use NK cell as monitoring in immunotherapy. So this first step. Second step is looking about NK cell receptors that we know to start before and after checkpoint inhibitor. And we also look how tumor stroma interaction can modulate NK cell activity and how to use NK cell in the future. In this moment, we just apply an basic research. How is NK cell working after transplantation? We report first data that after transplantation of hematological disorders, we have CD34 cell in periphery, and we use CD34 percentage of cells as good marker for people who respond and non-respondent on therapy. Now, in this moment, we calculate all data about NK cell activity, NK cell receptor, NK cell population in comparison to level of CD34, because all CD34 cell in the peripheral give a restoration of full immune system. So we'll look now about possibility to how after transplantation and after delete minimal residual disorders, restoration immune system will be achieved, and we have no data in this moment. Second option is use NK cell based on specific characteristics that kill tumor cells differently to T cell. There is one option to in vitro or ex vivo expand NK cell activity, use in vitro back to patients, induce therapy with activated NK cell. This protocol is different to lymphokine activated cells that started many years ago, because we now apply and reinfuse only activating NK cell. There is different protocol that is start now in different centers in Europe or America, and this therapy also involved CAR NK cell therapy and modality to kill tumor better using immunotherapy. Now, all time, my idea is that during all procedure we need to looking NK cell activity at good marker possibly to analyze immune system. Based of many data that I'm present for short time, I believe that analysis NK cell can help to looking immunomodulatory therapy, immunosystem. Different methods exist for determination NK cell activity, but we need to select one of that all time to use and compare data obtained before and after immunotherapy. We can use ex vivo, in vitro assay. Also, we can option to look intracellular cytokine amount in NK cell, and we have also two option to looking NK cell activity during immunotherapy that I really believe that may be helping in resolve some problem. Of course, I would be like to thanks expression to and congratulations to my colleagues who working with me many years 11 years together, Professor Gordana Konjic, who stopped to work, and my other colleagues in Institute of Oncology in Belgrade, and also many my colleagues participate in this project, because this project involved clinical center oncology in Novi Sad, Belgrade, Kragujevac, in Niš. This is only one small part working in immune system, second part is working in biochemistry, and next part is working molecular markers. So we just try to explain how NK cell play any good role in immune system, and I believe that using NK cell activity we can monitor better than using other parameter immune system in patients with cancer. So thank you very much for your attention.
I'm proposing to continue with more tumor presentation, and then we'll have discussion.
Again, I'm short maximally. How many? 15 minutes?
Yes, great. Thank you. Thank you. Sorry. So the next speaker is my colleague, Professor Klisarovska. She's also head of Department of Oncology at University Clinic at our university. And she will talk about prediction of toxicity of immunotherapy in general. Please.
Greetings to all. It's my honor and pleasure to be here with all of you. Thanks to the organizer for the invitation. This session, the topic is toxicities from the immunotherapy, so accordingly my presentation is about the possibilities for its prediction. Immunotherapy represents a significant step forward in the clinical practice of medical oncologists. It is the one of, just a moment, please. Okay. I don't have a look at the precursor, sorry. Не го гледам прекурзора, за да можам овде да гледаш.
Не, тук ми совете, што се кажа.
Ама не ги гледам до крај, не е важно, ќе се снајдам. Не го гледам кој. Работеше преска. Гледаш тука да може да спуштам, ама не може. I'm sorry for this technical problem. Okay. Immunotherapy represents a significant step forward in the clinical practice of medical oncologists. It is one of the most promising cancer treatments, as it can turn the power of the immune system against cancer cells. The cancer immunity cycle is defined as a series of functional stepwise events. The process is initiated by the release of neoantigens that are captured by dendritic cells, migrate to lymph nodes, and activate tumor-specific T cells. They migrate and infiltrate the tumor stroma, where they are potentially able to recognize and eliminate cancer cells. Knowing this cycle allows targeting different steps of the cycle in order to maintain its functionality. In addition to the different mechanism of action, it is necessary to know the side effects as well. The table shows the most common immuno-related adverse events. Early recognition and adequate management are critical to the patient prognosis and overall survival. The continuous development of immunotherapies is a revolution in the history of cancer therapy, but a major challenge associated with their use is the concomitant immune-related toxicities that presents a challenge to oncologists. Toxicities may involve non-specific symptoms of multiple systems, but also have a unique formation of a unique mechanism of formation, difficult to distinguish from the traditional toxicities. Some adverse events are self-limiting and manageable. Others may limit treatment, cause discontinuation and require treatment, or even be directly life-threatening. Therefore, the correct balancing between expected efficacy and induced side effects is crucial for successful treatment. The exact balancing act between efficacy and toxicity depends on established parameters, biomarkers. According to them, the correct grouping of patients is possible. Grouping is important because immunotherapy in general shows significant efficacy in multiple types of cancer, but only one subpopulation of patients has an apparent tumor response and long-term survival rate after treatment. A large number of patients may experience other adverse clinical features such as pseudoprogression, immunorelated adverse events, even hyperprogressive disease. An area of growing interest is the identification of biomarkers to predict immunorelated adverse events. Effective biomarkers are expected to predict toxicity, according to which patients will be filtered. It is necessary to select from the total patient population those who can benefit the most from these therapies while avoiding the unnecessary toxicity or avoiding the high risk of toxicity. At this moment, most of the biomarkers are used to assess the efficacy, and a smaller part of them refer to toxicity. I will briefly mention several types of risk factors correlated with the toxicity of immunotherapy, although some of them have not yet been clinically confirmed due to the limitation of the studies, because larger prospective studies are needed. Biomarkers can be analyzed, divided into derived from cancer cells, from the tumor microenvironment, from the host, peripheral blood biomarkers, or simply biomarkers derived from the tumor or from the immune system. The up and down arrows represent the increase or decrease of biomarkers. All these factors are associated with an increased incidence of immuno-related toxicities. First, about cancer cell-derived biomarkers. PD-1 molecule is an inhibitory receptor that was expressed on activated T cells and avoids unwanted inflammation and tissue damage caused by the excessive activation of T cells. But tumor cells take advantage of immune tolerance mechanism by upregulating the expression of PD-1 ligand, PD-L1 and PD-L2. Subsequently, the binding of PD-1 and its ligands in the peripheral tissue inhibits those already activated T cells in the immune response. PD-L1 is the most studied and reported biomarker for immune checkpoint inhibitors' efficacy. Theoretically, the more PD-L1 is expressed, the stronger immunosuppressive effect will be generated and the greater benefit will be achieved. However, other studies show that PD-L1 negative patients can also benefit from immunocheckpoint inhibitors. The production of monoclonal antibodies target the PD-1, PD-L1 signaling pathway to mobilize the host autoimmunity system for an anti-tumor response. But it can also provoke powerful autoimmune reactions in other organ systems classified as PD-1, PD-L1 inhibitors related toxicities. Toxicity can be serious, especially if the treatment is a combination of multiple immunotherapy drugs. Tumor mutational burden, the total number of somatic codic mutation in a tumor, is a promising biomarker for immunotherapy response in cancer patients. Higher tumor mutational burden results in more neoantigens, increasing chances for T cells recognition and clinically correlates with better outcomes. Higher tumor burden was observed as a significant independent predictor of severe immune-related side effects and poorer survival. Defect in mismatch repair can lead to microsatellite instability high, which can be found in many types of cancer. Microsatellite instability high or mismatch repair deficient tumors have an accumulation of errors in genetic sequences. They make the immune microenvironment of the tumor more sensitive to immunotherapy. They are among the main predictive biomarkers for personalized treatment to assess patients according to expected efficacy. But regarding with toxicities, there are still insufficient data. Immune-related adverse events have not been well evaluated in patients with microsatellite instability high cancers treated with immunotherapy. The tumor microenvironment is rich of biomarkers expected to predict response to immunotherapy and their impact on toxicity. Those high tumor infiltrating lymphocytes in tumor microenvironment have been shown to be associated with a better prognosis. Recent studies suggested that tumor infiltrating lymphocytes may predict response to immunotherapy, but more data is needed to assess the role of tumor infiltrating lymphocytes in patients treated with immunotherapy. Identification of super exhausted T cells represent a novel population that predicts response to immunotherapy. Patients with a super exhausted high tumors had higher objective response rate compared to super exhausted low tumors. Super exhausted T cells are a potential biomarker associated with increased T cells activity against antigens present in tumor and healthy tissue. Specific TCR sequences predispose cancer patients to specific organ toxicities. For example, a fraction of CD8 plus effector cells is associated with arthritis. A larger fraction of CD4 cells is initially associated with pneumonitis and thyroiditis. A decrease in the percentage of TREX may be associated with greater toxicity colitis. The major histocompatibility complex human leukocyte antigen has a key role in the activation of an appropriate immune response of the host against pathogens and tumor cells. Several lines of evidence have shown that downregulation of HLA class I expression is a tumor immune escape mechanism and is often associated with poor prognosis in cancer patients. In addition, it has also been shown that HLA class I and II antigen expression can predict tumor response in cancer immunotherapy. However, the role of HLA in predicting tumor responses to checkpoint-based immunotherapy is still debated. The dynamic balance of intestinal microflora plays an active role in maintaining the homeostasis of the immune system. The use of antibiotics has been associated with reduced efficacy and increased toxicity. Recent studies have reported that immunotherapy in patients with excellent performance status has better efficacy and less toxicity. Poor performance status is also associated with predictive hyperprogressive disease, such as rapid tumor progression during immunotherapy. Higher body mass index is associated with better response and less toxicity in immunotherapy. Studies report that severe form of toxicity more often occur in younger patients, but it is considered that the age cannot be used as an independent factor, biomarker, it should be combined with other biomarkers. Studies has found that a history of autoimmune disease is associated with the development of serious toxicity, and in autoimmune disease, we, like oncologists, we should be especially careful about immunotherapy treatment. In virus-associated tumor, such as cervical and gastric cancer, research has shown that viral infection can be used more as a potential biomarker for immunotherapy efficacy, and it is higher in virally associated tumors. Studies has shown that corticosteroid use is associated with poor clinical outcomes. It is difficult to find efficient biomarkers to predict the occurrence of immunorelated adverse events in the early stage. Studies has reported that PET-CT can predict thyroiditis in lung cancer patients, which is manifested by increasing uptake of FDG in the thyroid gland of patients on PET images. CT-based imaging can predict immune-associated pneumonia. Circulating biomarkers, circulating blood cells, have a potential predictive role for the development of toxicities associated with immunotherapy. Low neutrophil to lymphocyte ratio and low platelet lymphocyte ratio are considered independent predictive markers for the development of toxicities. Cytokine release syndrome is a serious adverse event. It is a phenomenon of immune hyperactivation which results in excessive secretion of cytokines and, if not controlled, can lead to multi-organ failure and death. It is a non-antigenic toxicity associated with hyperactivation of the immune system. Biomarkers have proven value in predicting response to immunotherapy. This enables the correct selection of patients who are expected to benefit from immunotherapy and patients who are not expected to have a good response. Selection allows avoiding rapid progression of the disease in those who do not respond, thereby avoiding unnecessary toxicity. In conclusion, there are several types of potential biomarkers, but for most of them, first, further studies are still needed to confirm the predictive value of potential biomarkers and to identify other risk factors for immuno-associated side effects. Second, with changes in the immune microenvironment and tumor status, most biomarkers require dynamic monitoring and combined analysis for a more comprehensive and accurate prediction of possible risk and their management. Third, immune-associated side effects with predictive biomarkers are still under investigation. It is of great importance for oncologists to determine different types of potential biomarkers through which the risk-benefit ratio for individual patients will be assessed in order to maximize therapeutic benefits and minimize toxicity. In the future, the focus should perhaps be on effective screening on the benefit-seeking population through the diversified detection based on liquid biopsy and the combination of new immune toxicities related biomarkers. Furthermore, a precise strategy should be applied in the management of immune-associated side effects according to the patient toxicity characteristics related to cellular and molecular mechanism including T cells activation and inflammatory responses. How to convert the non-targeted population into a target population. How to make immunotherapy more precise, controllable, with less toxicity and long-term benefits. I hope that we will be the focus of future research on predicting immunotherapy toxicity. Thank you.
Zarovska, but we'll continue with Lydia, and on the end we'll wrap up the day and the session and questions and answers, which are probably Professor Lydia Kandov. She is a professor in dermato-oncology from Military Medical Academy in Belgrade, Serbia.
Okay. Dear colleagues, thank you for being here so late today. I will switch from this topic of biomarkers that we really need for these immune-related toxicities to a more clinical lecture about what we do nowadays with our patients that we are treating with immuno-oncology therapy. So we know you have heard today that there is a revolution going on still in metastatic melanoma treatment. We have started with BRAF/MEK inhibitors because BRAF gene mutation was found as an early event in oncogenesis, and this is why targeted therapy is very effective in up to 60% of patients that are BRAF mutated. And also melanoma is a tumor with a high mutational load, and this is why several options for immunotherapy are really effective, including checkpoint inhibitors, but also in recent times also autologous tumor infiltrating lymphocytes therapy or adoptive T cell transfer. And furthermore, we have some of the tumors, some of melanomas like uveal melanoma that are resistant to checkpoint inhibitors. And so we have more options with CAR T cell therapy, adoptive T cell therapy, and other options that we try to modulate the immune response to tumor. But here today we will focus on checkpoint inhibitor therapy and its toxicity. And these are what we have now with checkpoint inhibitor therapies. You know that metastatic melanoma before 2011 was a deadly disease with 10% of patients alive after 40 months of follow-up. But now we have in 5 years overall survival of 50 to 60% of patients if we use combination immunotherapy with checkpoint inhibitors, CTLA-4 PD-1 antibody. And this is if we have, of course, all these drugs available and at our hands, which is not the case in many countries still. So we use this checkpoint blockade to activate the anti-tumor response. And in health, you see here that our immune system is clearing malignant cells and pathogens also effectively. But to shut down the immune response when we have the clearance of malignant cell or pathogens, we need to shut down the immune response. And this is why we have these checkpoint inhibitors, and our colleagues immunologists very well know that. But what we use is to block these checkpoints in order to again activate anti-tumor immunity. And because cancer cells and melanoma cells are actively shutting down the immune system, so they increase the expression of PD-1 molecules on tumor infiltrating lymphocytes, which causes immunosuppressive environment, and it allows cancer or melanoma to spread further and to progress. So in tumors we use the checkpoint blockade. While in some autoimmune diseases, we use checkpoint stimulation. So we want to shut down the overstimulated immune response. So this is how we modulate the immune response in current modern therapy. But because of this, when we use checkpoint inhibitors, our patients develop different types of autoimmune diseases. And in this scheme, you can see that we have different pathomechanisms for these adverse events. So, for example, if we have T cells that are activating and reacting to antigens in the healthy tissue, like melanocytes, we will have vitiligo or we will have myocarditis. So if we activate cytokine-mediated immunity, our patients will develop colitis, arthritis, or psoriasis, or eczema. And also if we activate antibody-mediated autoimmunity, we will have thyroiditis, or, for example, in the skin, bullous pemphigoid. So we will have autoimmune bullous diseases that can develop, or some neurologic manifestations like myasthenia gravis, or myelitis, or autoimmune encephalitis. And also if we have expression of target, for example, CTLA-4 molecule in normal tissue, we will develop hypophysitis, and those patients that develop hypophysitis are usually treated with ipilimumab because it is anti-CTLA antibody. So this is the mechanism of these adverse events, and we will really need some biomarkers to predict which patient will develop toxicity, because it will help us to choose the upfront therapy, or whether are we safe enough to use the combination therapy or to use only monotherapy. Anyway, immune-related adverse events can develop in any organ and are really unpredictable. But what is I have to say is that 90% of our patients will really go well if they are treated with monotherapy with anti-PD-1 antibody. Many of them will just have no adverse events, but some of them will have rare adverse events that are can be also life-threatening and persistent, and this is a problem. So I will speak first about the frequency of adverse events, and what we know is that if we use only one checkpoint inhibitor, anti-PD-1 antibodies, we will have the frequency of these adverse events will be from 38% for example for anti-PD-1 antibodies to 54.6 for ipilimumab, for example, if we talk about the skin. But if we combine both of these checkpoint inhibitors, then we have the large increase of the frequency of adverse events, and you can see here that even 95.8% of patients can have some sort of immune adverse events, and grade 3 to 4 can be found in up to 60% of patients. Also, we have really different time points when these immune-related adverse events will happen. So you can see that skin will react, reactions will come first. Then we have, from this week 4 to week 6, we will have diarrhea or colitis. Hypophysitis we can expect after 6 weeks, and liver toxicity also after 6 weeks. What is also evident that if we combine two checkpoint inhibitors, we can expect these toxicities much earlier. We can expect them even in the first week after the first infusion. So we will always have to be vigilant and to look at our patients and be in contact with them to early recognize them and react and treat them. What is also evident is that there are differences in the pattern of these adverse events between different tumors. So also between different molecules. For CTLA-4, for ipilimumab, we will have more frequent colitis and hypophysitis. And then if we look for PD-1, we will have more pneumonitis, we will have more hypothyroidism or arthralgia. And also, we will have differences between different tumors. So if you have lung cancer, or if the patient has lung cancer, pneumonitis will be much more frequent than if you treat your patient with melanoma with anti-PD-1 antibodies. And also, if you have RCC, renal cell cancer, you will have more of arthralgia and hypothyroidism, and in melanoma, in comparison to melanoma, and more pneumonitis if you compare in melanoma than in RCC. Also, so this was also evident in this table. And there are several factors, predictive biomarkers, that were already mentioned, but still we don't have something that we can really rely on to predict which patient will develop severe grade 3 or 4 toxicity that can, we just have to treat the patients and really have a close follow-up. How these side effects are manifested and what is their treatment. So what we have to do is to early detect this, to treat them, and to monitor our patients. Prevention and anticipation is not something that we can do at the moment. But what we can do is to select our patients, and if they have the autoimmune disease, and if it is active, like inflammatory bowel disease or something which is active, not out of control, we will certainly not use combination immunotherapy. Regarding the management of the toxicities, there are several guidelines that are updated once in a while. And we also have, for this management, always we first do the grading of the toxicities and then use these algorithms that are very useful for the beginners. But in general, the management is that for grade 1, we can continue therapy and do this, give just the symptomatic therapy. For grade 2, we will hold the ICE therapy, do the diagnostic workup, and then reintroduce when the grade of the adverse event is going down to grade 1. For grade 3, still we can consider resuming ICI, but if we have the grade 4 toxicity, we should permanently discontinue checkpoint inhibitors and, of course, hospitalize patients if it is grade 4. Regarding the corticosteroid use for these toxicities, we use them often as the first line, and we use them in high dosage. We use them in up to 2 milligrams per kilogram because we want to early react, stop this, go to grade 1, and continue, if we can, the treatment. There are some specificities for dermatological toxicities, and there are now new European recommendations for management of these dermatologic adverse events because they are the most frequent one, and they can vary from pruritus to vitiligo to really different autoimmune and immune-mediated toxicities that we see also as dermatologists in everyday practice, like idiopathic dermatosis. Timing of onset of cutaneous immune-related adverse events is also different for different entities. For example, pruritus can develop in the first weeks, and also severe dermatologic toxicities like Stevens-Johnson syndrome, toxic epidermal necrolysis, or DRESS syndrome can develop also in the first week. So we have to be very careful to explain our patients to come back to us and to come back to if they notice anything on their skin, which is not the case. So many times our patients just neglecting their symptoms and wait for them to resolve. This is the frequency of dermatologic side effects, and also we see that for some therapies, again, if we have the combination, the frequency is higher. So the pruritus can be seen in up to 50% of patients, and maculopapular rash in up to 70% of patients, vitiligo in up to 25% of patients, and for example, bullous pemphigoid can develop in up to 5%. This is more rare. This is one of the studies that deal with these cutaneous manifestations throughout Europe. It's called MELSKIN Tox, and what was noted in this study is that in majority of these skin toxicities, treatment was continued, so we are able to control these side effects effectively and continue the treatment. And what was also evident is that patients that develop these dermatologic toxicities has better efficacy, and if you can see here that if the grade of toxicity is 3 or 4, much more patients will have the complete response. This is because we effectively activated the immune system. The anti-tumor response is activated, but then also some autoimmune phenomena are also activated, and we have the skin toxicity or some of these manifestations. So this is one of our patients with mucosal melanoma. BRAF mutation was not detected, and what was she was treated with pembrolizumab, and after 3 weeks she developed first the maculopapular rash with intense pruritus. We started, of course, based on the recommendations, the moisturization, the antihistamine, local topical steroids. You have all these algorithms in these guidelines that we have now. But what happened next is that this patient developed aggravation of pruritus, and first this appearance of vitiligo-like depigmentation after 3 months, as you can see here, which is extensive. Later on, this patient also developed total alopecia areata, another autoimmune condition. But what was also evident is that we were very happy when we see that she developed vitiligo, because we know that it can be a biomarker of a good response and durable response based on this study. And this was also the case with our patient that developed complete response, and it was a durable one. What we also see in everyday practice is changes in the melanocytic nevi and disappearance of nevi on checkpoint inhibitor therapy. And this is one of our patients that is treated with also again with pembrolizumab. And you can see that all these moles, melanocytic nevi, are disappearing, or they are losing the pigment on therapy. Also here, the depigmentation can be seen in association with vitiligo, but what was interesting is that in this article it was described that patients with lung cancer treated with checkpoint inhibitors have actually hair repigmentation with immunotherapy. This is also 2 of our patients that developed lichen planus, one of the most common dermatologic diseases that we also see in our everyday practice. And we have these new guidelines that is very useful to see that we can use all the other drugs that we use for lichen planus, like acitretin, retinoids, concomitantly with immunotherapy if we have the more severe disease, and if we cannot control the immune related adverse event with topical therapy. This is another patient which also developed cutaneous and pulmonary sarcoidosis, also on pembrolizumab therapy. And also one of our patients that developed scleroderma-like reaction. So we treat these patients usually with corticosteroids, what we found in the literature is that this scleroderma-like reaction is more prevalent with pembrolizumab than with nivolumab. So there are some really interesting data that we learn during the years about these toxicities, and they are the most frequent, and we need to have the better control, early detection, all these skin toxicities, because if we treat them and in collaboration with dermatologists, we can treat them effectively. We can ensure the better compliance to treatment, to continue with immunotherapy and not to stop the treatment and switch to other forms. Now we are going to endocrine toxicities. This is again one of our patients that was treated with pembrolizumab, and she developed tachycardia and sweating, and of course we suspected hyperthyroidism because Hyperthyreosis is something which is more, and then later hypothyreosis is something which we really frequently seen in up to 10% of our patients. So we will certainly not stop the immunotherapy for this autoimmune thyroiditis. And this is how in our patient we have first the increase of FT4 and FT3 and decrease of TSH, and then it switched to hypothyreosis, and then the hormone replacement with levothyroxine was introduced, and she's continued with the immunotherapy. This is another patient of ours with metastatic melanoma that was treated in the first line with combination of nivolumab, ipilimumab. He developed fatigue and fever, and when we have fatigue and fever, we always, of course, look for the viral infection, but then we also have to have in mind the autoimmune hypophysitis, which is more common with ipilimumab than with nivolumab. So we did do these cortisol, FT4 and TSH, and we with brain MRI diagnosed this autoimmune hypophysitis, which is treated with lifelong hydrocortisone therapy. So this is persistent side effect, and this patient has to be on hydrocortisone for his life, and also L-thyroxine for substitution. Another common, relatively common, and it can develop in up to 3 to 5% of patients, side effect is colitis. So one of these patients developed diarrhea, and we have to be very vigilant about diarrhea and colitis, because it can lead to bowel perforation and death if we don't react very quickly with high doses of corticosteroids. But if after 2 days it's not effective, we have to switch to infliximab and anti-TNF inhibitors. Also, we have some of patients that already have inflammatory bowel disease, and we then have to have our gastroenterologists in place to see how to prevent more severe side effects in those patients, and to pre-treat them and treat them before we start the immunotherapy. What is more frequent in lung cancer when you treat with checkpoint inhibitors, and is less frequent in melanoma, is pneumonitis, and it's more common with anti-PD-1 than with anti-CTLA-4. And so, if we have dyspnea, we have to diagnose it and see whether we have on CT scans pneumonitis or it is something else. We have some patients that develop new asthma that they didn't have before with checkpoint inhibitors, and we also again have to have a lung specialist to help us. But what we fear the most are the rare immune-related adverse events, and some of them, many of them are persistent, and many of them are really hard to treat. You can see here the incidence of these rare side effects. Some of them are neurologic, and the incidence is from 1.75, 0.3 to 3.4 in this cohort. With combination, it is again more frequent. We have the neurologic one, we have the cardiologic one, myocarditis, myasthenia gravis, and so on. We see that with these severe adverse events, we have this new article from 2022 that we cannot still have these biomarkers. We cannot find anything that can predict that some of our patients will develop. This is one of our patients that was treated with pembrolizumab and first developed hypothyroidism, but then he developed vertigo, nausea, and fatigue. We thought that he had new brain lesions, but the MRI was normal, and we suspected that maybe we have some rare neurologic side effect. We did all the tests and find that there were neural specific antibodies that were found in the serum, but not in cerebrospinal fluid. And when we started we of course stopped the anti-PD-1 antibody and started methylprednisolone on 80 milligrams per day, but then he didn't feel, he went to somnolence. We started with pulse corticosteroid therapy for 5 consecutive days, and he was getting better. And these side effects are really concerning. We have myasthenia gravis, myositis, Guillain-Barré syndrome that can develop, also aseptic meningitis or encephalitis that can develop in 0.1 to 0.2% of our patients. And what is always also a challenge for us, if we don't have another option for our patients and if the disease progresses, can we reintroduce these treatments again in patients that had severe immune-related adverse events? And there are data now that we have that if we don't have other options, we can maybe re-challenge and have the risk of up to 40 or 55% of our patients to develop again this toxicity, but another 50% will not develop it, so we can really discuss it with the patient. In summary, what we have to do to be vigilant, to diagnose our adverse events, to grade them, and to treat according to management principles. And what we do in everyday practice is to have these all these analyses before immunotherapy. One of the new concerns is cardiotoxicity, and this is some of the experts' advice to also have basic troponin levels also used before the therapy and monitor them after that. And also during the immunotherapy we monitor especially thyroid gland, all these laboratory analysis, and if some of the symptoms develop, also stool calprotectin, CRP, glycemia, cortisol, because we have also cases, at least 3 from our practice, of new onset diabetes mellitus on checkpoint inhibitors. And also we have this group of questions that we always ask our patient before every treatment cycle. And what is also very important is to establish the immuno-oncology team for toxicity, to have the specialists that know this treatment, these relatively new treatments, to have them on hand, on access, to have them for the consultation on how to treat our patients together with specific diagnostic tools to diagnose different manifestations. So in conclusion, we have newly described but still poorly understood side effects of checkpoint inhibitor immunotherapy. We have the recommendations that we should follow, but we have to also be very personalized. We have to have the personalized approach to our patients, have in mind all the comorbidities and age and everything else, but also treat aggressively in order to obtain the continuation of our treatments in this disease. Also to have in mind that maybe some symptoms can be the symptoms of disease progression or the infection or the other comorbidities. And also early detection is very important to avoid grade 3 and 4 toxicities, but because if we have grade 4 we cannot continue our treatment. What is good is that we have data that patients that develop grade 3 or 4 toxicities have better outcomes, and even if you stop the treatment, you will have the durable response. And also it is necessary to have our team in hands in our hospital for efficient monitoring of our patients. And with this, I thank you for the attention.
About therapy, corticosteroid, you mentioned 2 milligram per kilogram. For which indications it means? For this site.
You can hear.
Ah, sorry.
You can hear, so you can speak it. You can speak.
Okay.
So I said that we start usually with higher, at least 1 milligram, but then if it's not getting better, we switch to 2 milligrams or even to pulse corticosteroid therapy, because we want, I'm talking about colitis, I'm talking about this patient with encephalitis, pneumonitis, so these are really concerning side effects. For skin toxicities, of course, if we have 10 toxic epidermal necrolysis, we have one, not for with immunotherapy, we had it with BRAF/MEK inhibitors. We also started, like we do for 3 days pulse corticosteroid therapy, and then very quickly get off the corticosteroid treatment. Now we have one patient with bullous pemphigoid induced with, and we also started with, I think, 1 milligram, and then we decreased it.
Decrease the dose.
What we see is that some of these toxicities are more persistent than idiopathic diseases, skin diseases. So they are more.
Longer
yeah.
Thank you very much.
Thank you. Vladimir?
Thank you very much for including table about frequency of side effect. But this is very nice and very useful from 2017, but now is absolutely changed, because when introduced 2 drugs, we have absolutely overlapping, and there is new classification that you need to speak a little more about stress in the multi-organ. We have several side effects in last period, including application to immunomodulatory therapy, because only once, and what you, my question here, what you in this case apply this therapy, and if you successful therapy, in which type of therapy mostly use in stress distress syndrome or multi-organ dysfunction, because it's classified not only hyperthyroidism but in lymph node.
You mean multiple endocrine syndrome?
And stress syndrome.
So for I didn't have a patient with stress, but I had a patient with hypothyrosis, diabetes, adrenal insufficiency. So yeah, of course we do the hormone replacement therapy, and small doses of 10 milligrams of hydrocortisone and so on. I don't know what was the other question. Can I ask you?
No, okay.
Can you just?
Yeah, because we try to apply anti-IL-6 therapy, but this is very tricky because it's other problem, like to treatment during SARS-CoV infection.
IL-6.
Problem because if you apply, there is also need to monitor level of cytokine. I thought tomorrow, because we have also experienced that if you applied IL-6 blocker antibody so late, we have no good effect. We need to look and monitor IL-6 level and progression of IL-6 level during first 24 hours. If you multiply level of cytokine, it's good candidate. If you go values so high, it is no effect.
Yeah, IL-6 antibodies in our guidelines is not something that is usually used. Sometimes it can be maybe a second or third line option. What we usually use is corticosteroids. We use for colitis, I already TNF blockers. We use for autoimmune hepatitis, which we frequently see. We use, of course, again steroids, but also mycophenolate mofetil. So this is something that is usually done. But yeah, there are certain situations that we need some advice for multidisciplinary, and in new therapies we don't have much of the evidence how we can combine these new antibodies for our purposes. For example, there are some new data that, for example, TNF blockers can also decrease overall survival in patients that were treated for immune-related adverse events. And then you can some advocate for vedolizumab, for example, for colitis, not for TNF blockers. So it's really a complex, and we need more data. We are somewhere in the dark, and But can I ask you about the NK cells? Are really promising in like new treatment approaches. Have you considered doing the monitoring of NK cells in the patients with metastatic melanoma treated with checkpoint inhibitors.
This will be sent for newest results will send 2 or 3 days before to new journals, but I don't like about this because we're looking for activating an inhibitory receptors, and absolutely we have
some signals
difference, and this is good marker really. And tomorrow I will speak about cytokine that we established already and published it. I thought
but do you think
IL-6 is good marker to precede side effect, to precede not respond to PDL therapy because the high level of cytokine induce like to many other inflammation. There is associated with non-responders.
Yes, it's the same like CRP. When we have a patient with high CRP, it's really advanced disease. So it's in correlation with IL-6.
But we have also results about, I talk tomorrow about.
Okay, but my question is.
NK cells will be looking for activation and inhibition. That this is big problem because this is level of PDL on NK cells is very low. So this therapy probably not trigger NK cell much more contrary to other cells. We compare level of PDL on T lymphocyte, on the NK cell, but maybe is effect cumulative. Maybe you block something that we don't measure it exactly, but we achieve effect. This is also situation if your level of PDL1 is low, we achieve effect.
Yes.
But in some time, level of PDL1 is high, maybe we cannot block efficiently, and we have failed. So immunotherapy is really, really complex. Depending on receptor expression, depending on neutralization, antibody is not so good for monitoring. Only cells, only activation receptor. This is my experience. Receptors, production of cytokine from separated cell because it is effector molecule to kill tumor. I'm saying before, if your capacity of effectory cells to kill tumor is low, we cannot achieve
of course.
Any pressure, anything.
Anymore.
More therapy cannot make better results because its capacity to kill tumor is limited. This is problem.
Okay, we are finishing for today. Tomorrow we are starting at